multiple products for acne and acne.
Very good evening, guys. Welcome back. Welcome back to the platform of Dr. Bhan Prakash, sir. So now what we'll discuss. So my name is Dr. Ramya Sri. I will discuss obstetrics and gynecology in a crisp manner in this video. So yesterday we have done the first part of this video where we have discussed obstetrics, but we were left with the labor. So now I'll discuss about labor and then we'll start with the gynecology. Very good evening, RS. Good evening to all of you. Right. So let us start with the labor. So we'll start with the revision of labor and then we'll go to the gynae. So first, how many stages of labor do we have? So we have 4 stages of labor. We have 4 stages of labor. Stage 1 is from the onset of true labor pains to full dilatation. Whereas stage 2 is from full dilatation to expulsion. Stage 3 is expulsion of placenta. Stage 4 is 1 hour observation post-delivery. Right? So stage 1 is from the onset of true labor pains to full dilatation. Stage 2 is from full dilatation to expulsion of the fetus. Stage 3 is expulsion of placenta. Stage 4 is 1 hour observation post-delivery. Labor is very important. You tend to get questions on the labor and you should be in a position to solve the questions when you get the question from the labor, right? So first starting with the first stage. So first stage is further divided into latent phase and active phase. First stage is further divided into latent phase and active phase. So latent phase is up to old was as per WHO Partogram, but you also now know that WHO Partogram is outdated now. So as per modified WHO Partogram, latent phase is up to 5 centimeters. Active phase is 5 to 10 centimeters. So as per WHO, modified WHO Partogram, latent phase is up to 5 centimeters and active phase is 5 to 10 centimeters. Right? Next. Very good evening, Medicos FMG. Yes, this is my second part of the video. First video is already there. Yesterday evening, I've taken the first part. This is the second part, but it's okay. You can hear from here because this is the labor, which is very important. Followed by, I'm going to do the gynec in this session. So latent May, hi Bunny, good evening. We have modified WHO Partogram. So if in the exam, if somebody asks you latent phase is up to how many centimeters, the best answer what you can give is up to 5 centimeters. And active phase is 5 to 10 centimeters. Next, coming to the ACOG. ACOG tells that, so according to modified WHO Partogram, up to 5 centimeters is the latent phase. 5 to 10 centimeters is the active phase. ACOG tells latent phase is up to 6 centimeters and active phase is 6 to 10 centimeters. Am I clear? In exam, what are you going to consider as the active phase? In exam, you're going to consider active phase from 5 to 10 centimeters. Now, I'm going to tell you some terminology, some numbers here. Latent phase, primary, multi. So latent phase, what is the average duration of the latent phase? The average duration of the latent phase in primary is up 10 to 12 hours. And for multi, it is 6 to 8 hours. And when do you call prolonged latent phase? More than or equal to 20 hours for primary, more than or equal to 14 hours for multi. Basically, latent phase में, whether it is prolonged or whether it is normal, we are just going to watch for the progress of labor. So what is the simplest idea which should be in your brain is, up to 5 centimeters, you're going to just watch for the progress of labor. Up to how many centimeters, you're just going to watch for progress of labor and not do anything. Up to 5 centimeters, you're just going to watch for the progress of labor. For your exam purpose, just remember this. So whatever they might tell, like she was 2 centimeters, now at 2 p.m., at 10 p.m. she became 5 centimeters, fine. Latent phase, let it take its own sweet time. So latent phase may basically just watch for progress of labor. Okay. Active phase. Again, primary, multi. Active phase में rate of dilatation, rate of descent. Rate of dilatation and rate of descent. So primary में the rate of dilatation is 1.2 centimeter per hour, whereas multi में it is 1.5 centimeter per hour. Rate of descent is 1 centimeter per hour and 2 centimeter per hour. You have to imprint this in your brain. So all these are very important and has been asked previously. So you should all remember this, right? So primary में rate of dilatation is 1 centimeter per hour and multi में 1.5 centimeter per hour. Rate of descent 1 centimeter per hour and 2 centimeter per hour, right? According to WHO, everything should be minimum 1 centimeter per hour. Whether it is rate of dilatation or rate of descent, it should be minimum 1 centimeter per hour, according to WHO. There are two abnormalities in active phase. One is prolonged active phase, another is protracted or active phase arrest. Whenever active phase is taking slow, whatever time duration I gave you up, no, if it is happening more than that, we call it as prolonged active phase. So when it is prolonged active phase, yeah, protracted active phase, when it is prolonged active phase, yeah, protracted active phase, how do you manage? Check for the contractions per abdomen, contractions you feel. Guys, when do you call adequate contractions? How many contractions in 10 minutes is considered to be adequate contractions? So if they have inadequate contractions, then augment the labor, increase the contractions. If head is well fixed, you can do artificial rupture of membrane. If head is not fixed, give oxytocin. If head is not fixed, then you have to give oxytocin. Ziyad and Faye, welcome to the session. We are happy that you are watching from China. So per abdomen, if the contractions are adequate, that is, if she's getting 3 contractions in 10 minutes, then do per vaginal examination. On per vaginal examination, if you have molding, that is overlapping of skull bones, and if it is 3+, then it means it is a cephalopelvic disproportion. Whenever it is a cephalopelvic disproportion, you have to go for LSCS. On PV, if you see that there is OP position, you can wait and watch. Because OP ultimately will rotate. Okay? So this is about the protracted, yeah, prolonged labor. So what are you going to do when it's a protracted or prolonged labor? You are going to see per abdomen how many contractions she is having. If the contractions are adequate, that is, if she is having 3 contractions in 10 minutes, it means it is not the problem of the power. Let us see the passenger, passage. So I'm going to do PV for that. And in PV, if I feel head is squeezed, that is molding 3 plus, then I'm going to go for LSCS. And if the head is OP position, then I will watch for progress. Because in OP, 90% of the time, baby will rotate and deliver. Correct? So OP, there are some MCQs where they give you that on PV, OP is felt, OP occipital posterior. Then what you should do? Wait and watch. Inadequate contractions may you can augment the labor. Inadequate contractions may you can augment the labor. When do you call active phase arrest? So active phase arrest is when cervix is more than 6 centimeters dilated, membranes are absent, with adequate contraction, no dilatation for 6 hours, no dilatation for 4 hours, with inadequate contraction, no you can give oxytocin. You can give oxytocin. And no dilatation for so with inadequate contraction, you give oxytocin and no dilatation for 6 hours. Then you call it as active phase arrest. What will be the treatment for active phase arrest? LSCS. Treatment for active phase arrest is LSCS. Okay? Right. So that's about the active phase and latent phase. And normally in latent phase, you can review her every 4 hours, whereas in active phase, you have to review her every 2 hours. So let us solve this question. A 28-year-old in her first pregnancy is induced at term plus 10 days. CTG was normal before the induction of labor. She was dilated 6 centimeters 4 hours previously and is now dilated 8 centimeters. So basically, she's in which stage? She is in active phase. Active phase, ideally the rate of dilatation should be 1 centimeter per hour, but she was 6 centimeters 4 hours previously and now she's 8 centimeters. She has uterine contractions at a rate of 2 every 10 minutes. Yes, this is mainly for the aspirants in the last minute. Instead of you studying yourself, we are there just trying to help you out. Just chill and listen. That's all. Okay. CTG shows a baseline of 150, good variability, infrequent shallow deceleration. What is the next most appropriate action? Can you tell me what is the diagnosis here? What is the diagnosis here? If you tell me the diagnosis, then we can discuss the management. So this is, see, she was 6 centimeters 4 hours previously, and now she's 8 centimeters. When will you call arrest? After 4 hours, if she was still 6 centimeters, then I would have called it as active phase arrest. Arrest में बिल्कुल dilatation नहीं होना चाहिए, but यहाँ पे dilatation हुआ है. She was पहले 6 centimeter. 8 घंटे के बाद what did she become? Sorry, 4 घंटे के बाद she became 8 centimeter. मतलब भले ही 4 घंटे में थोड़ा ही dilatation हुआ है, but हुआ तो सही. Ideally कितना होना चाहिए था? 4 centimeter. 4 घंटे में 4 centimeter. As per 1 centimeter per hour if you take. So what will be this called as? Yes, excellent Bunny, excellent RS. This is prolonged labor, and this prolonged labor is mainly due to inadequate contractions. So what should be the treatment? So exam may also this approach you remember. Whenever you have a question, ask yourself which stage it belongs to. Once you know the stage, ask yourself, is it normal? Yeah, is it abnormal? Then you will understand the management appropriately. Any clinical question, follow this pattern. Okay? Yes. Excellent, Pratyusha. Very good, RS. So start oxytocin and oxytocin 2 hours because there are inadequate contraction and inadequate dilatation. Wonderful, guys. Let's go to the next one now. Second stage. Second stage is expulsion from the full dilatation. That is after 10 centimeters, expulsion is the second stage, right? So expulsion may, again, we'll see the time, primary, multi, primary and multi. Average duration, when do you call prolonged second stage? I think I need the next page. Yeah. So this is second stage, primary and multi. On an average, when do you call prolonged second stage? And when do you call second stage arrest? So primary and multi, when do you call average, prolonged second stage and second stage arrest? Okay. So primary may, on an average, it takes around 30 minutes. Sorry, 1 hour. Primary, you can remember the number as 1, 2, 3. So primary on an average will take 1 hour to deliver. Prolonged second stage is more than or equal to 2 hours. Second stage arrest is more than or equal to 3 hours. Primary on an average will take 1 hour. Prolonged second stage is more than or equal to 2 hours. Second stage arrest is more than or equal to 3 hours. Multi will take everything less. 30 minutes, 1 hour, 2 hours. Normally, how do we conduct the delivery in second stage? It's called Ridgen's method. When it is a prolonged second stage or second stage arrest, check the station of the fetal head. Check the station of the fetal head. If fetal head is above +2, go for LSCS. If fetal head is below +2, then you can do instrumental delivery. This is for both prolonged second stage and second stage arrest. And when you're doing epidural, when you're giving epidural, whatever I've written, +1 hour you have to add. If you are giving epidural, whatever I've written, +1 hour you have to add. Okay, guys? So that's about the second stage. That's about the second stage. So I hope you will be able to rock in the second stage. So what is this? What is this maneuver? This is nothing but the Ridgen's maneuver. That is where you do the controlled delivery of the fetal head between your two hands. This is called Ridgen's maneuver. Home delivery 2 weeks back. Now presents with complete perineal tear. What is the management? Whenever you have a perineal tear after 24 hours, you have to repair it after. You have to repair it after 3 months. Whenever you have home delivery after 24 hours, you have to repair it after 3 months. Within 24 hours, you can repair immediately. After 24 hours, you have to repair after 3 months. So answer here is 4. Coming to the third stage. Third stage is expulsion of placenta. So what is this maneuver which you're seeing in the picture? What do you call this maneuver? So third stage where you have two modalities of management. You have passive management and you have active management. What is the steps of the active management of third stage of labor? So the steps of the active management of third stage of labor, you can remember it as IDBI. IDBI, right? So we have immediate administration of uterotonic drugs, delayed cord clamping, control contraction, and intermittent uterine tone assessment. So active management of third stage of labor, you can remember the mnemonic as IDBI. IDBI bank is there, no? IDBI. So you got this sequence order in your exam. First step, what they have written in the exam was check that there is no another baby inside the uterus. Once you check there is no another baby inside the uterus, then you can give the uterotonic drug. Okay? What are the different uterotonic drugs which you can give for AMTSL? Yes, this is nothing but the control contraction, or it's also called as Brands-Andrew method. Brands-Andrew method. Okay, can you tell me what are all the uterotonic drugs you can give? What are the different uterotonic drugs which we can give? So the different uterotonic drugs which you can give are, you can either give oxytocin. See, most students think it's only oxytocin. Oxytocin 10 international units IM, or you can do delayed cord clamp, or you can give methergin 0.2 milligrams IM or IV, or you can give misoprostol 600 micrograms per rectal. So either oxytocin or methergin or misoprostol 600 micrograms you have to put in per rectal. Okay, so any of these three can be given. Delayed cord clamping, you have to wait for the cord pulsation to stop. You have to wait for the cord pulsation to stop, and then you clamp the cord. That is called delayed cord clamping. Early cord clamping is done in RH negative, when there is a fetal distress, when mother is hemodynamically unstable, when cord circulation is not intact. IUGR with abnormal Doppler. Cord circulation not intact is vasa previa, placenta previa, abruption. All these are cord circulation not being intact. Okay. Last I is intermittent uterine tone assessment. If the uterus is flabby, then you'll go for uterine massage. HIV is a big controversy, guys. In HIV, most guidelines say delayed cord clamping, but in our practice, we do early cord clamping. NACO also tells delayed cord clamping after the cord pulsation. Sorry, NACO tells early cord clamping after the cord pulsation stop. But if you're clamping after the cord pulsation stop, it is obviously early. It is not early, no, it is delayed. So I really feel HIV is a little controversial. Anyway, I've never been asked, so let us not break our head. So HIV may one thing which you should all know is breastfeeding. You baby can be breastfed. If you don't put this above hand, what can happen, guys? If you don't put this above hand, what can happen? What is the risk associated with this maneuver? Uterus can come out, and inside out turning of the uterus is called as uterine inversion. Uterine inversion. It's not prolapse. Prolapse and inversion mein what is the difference is, prolapse mein uterus will come out same like that only, but inversion mein uterus will turn inside out. Okay, so uterine inversion is inside out turning of the uterus. Uterine inversion is inside out turning of the uterus. Right now, what is the treatment of uterine inversion? Uterine inversion may there will be shock due to two reasons. One, it is due to the uterus coming out. There will be vagal nerve stimulation, so there will be vagal shock, and there is also bleeding. So there is hemorrhagic shock plus vagal shock. So here the sentence which they might ask you, this has been asked in the FMGE exam actually. So here shock will be out of proportion to the bleeding. Yes, shock is out of proportion to bleeding. Yes, there is both neurogenic shock and hemorrhagic shock. There is neurogenic shock plus hemorrhagic shock. So shock is out of proportion to the bleeding. This is mainly due to mismanaged third stage. What is the treatment for uterine inversion? Push the uterus back. Push the uterus back. That's called manual reposition of the uterus. So manual reposition of the uterus followed by removal of the placenta, followed by start oxytocin. See, actually, if uterus can go inside without any turbitalin, push it back first only. If it is not happening, if it fails, you are not able to push the uterus, it has gone into the contracted state in inversion state, that time you can give the terbutaline. Otherwise, terbutaline is not required. First, you try this way. If this is not helping, then you will go for terbutaline. If this is not helping, then you will go for terbutaline. नहीं, पहले आप नहीं दोगे, पहले जैसे बाहर निकला है उसको अंदर ढकेल दो. अगर ये हेल्प नहीं हो रहा है, नहीं कर पा रहे हो, तब टर्बिटालिन देंगे. ठीक है. राइट. ब्रीच में डिफरेंट टाइप्स ऑफ ब्रीच क्या क्या है? ये जो पैर ऊपर फ्रैंक ब्रीच, ये वाला कंप्लीट ब्रीच है, and this is the footling breech. So where the baby is doing tandav, this is the footling breech, right? So we have frank breech, we have complete breech, and we have footling breech. Which is the most common? Most common is frank breech. Highest chance of cord prolapse with footling breech. फुटलिंग ब्रीच का मैनेजमेंट क्या होगा? फुटलिंग ब्रीच का मैनेजमेंट क्या होगा? फुटलिंग ब्रीच वी हैव टू गो फॉर LSCS. फुटलिंग ब्रीच का मैनेजमेंट है LSCS, राइट? So frank breech is the best for vaginal delivery. Frank breech is best for vaginal delivery. Most of the time, complete breech rotates by itself and turns into cephalic. Okay. Now, whenever you have a breech, what will be the modality of management? Can you just brief me what will be the management of breech whenever you have whenever there's a patient with breech? So whenever there's a patient with breech, we wait and watch. Because most of the time breech can rotate. Right? So what are we going to do? We are going to wait and watch. Up to how many weeks? Up to 36 weeks. You can wait and watch. Up to 36 weeks, you can wait and watch. But after 36 weeks also, if bacha didn't rotate, then you have to try rotating the baby. So you'll do ECV, external cephalic version. You can do it from 36 weeks to term. Agar this fails, you can do reattempt. If it fails again, then you will go for either breech assisted vaginal breech delivery or you'll go for LSCS, depending on what are the other conditions available. So always remember, up to 36 weeks, you can wait and watch for the breech to rotate by itself. 36 weeks के बाद, 36 weeks to term, you'll do external cephalic version. अगर वो fail हो जाता है, तो then you reattempt it. If it fails again, then you can go for assisted vaginal breech delivery or LSCS. Now I have one beautiful question for you people to answer. This is actually PYQ and with one of my favorite question. A 34-year-old gravid to para 1 living one, previous classical is now having breech presentation, which is confirmed on USG at 34 weeks. The patient insists on normal delivery. What will you do? The patient insists on normal delivery. What will you do? Wait and watch. Plan cesarean section at 37 weeks. Repeat USG after a week and decide, and do vaginal delivery. right? Right. Ideally, yes, excellent, Raja Charan Sunny. Very good. So answer here will be classical, guys, because see, as what I've taught you is that 36 weeks tak you can wait and watch. But what you would miss is she's having previous classical. Once a classical, you cannot do vaginal delivery. Once a classical, you cannot do vaginal delivery. So that is why you have to plan for cesarean section at 37 weeks. So exam may you might have some twist and turn. So don't take everything like straight. You have to like little whatever that small two things together. You have to be in a position to answer. Okay. So when you have a previous cesarean section and if you are trying for a vaginal delivery now, that is called as TOLAC, trial of labor after cesarean section. So that is called as TOLAC, trial of labor after cesarean section. So TOLAC में so when you have a previous vaginal when you have a previous vaginal delivery, previous cesarean section, and now if you are conducting a vaginal delivery, that we call it as TOLAC, trial of labor after cesarean section. So what are the contraindications for TOLAC? So the contraindications for TOLAC are previous more than or equal to 3 lower segment cesarean section, previous classical, previous uterine scars due to surgeries like myomectomy or hysterectomy, previous rupture. So whenever any of these conditions are there, you cannot do the TOLAC. That is trial of labor after cesarean. Okay. Right. Now, can you tell me the names of different maneuvers which I'm showing you here as per the breech? What is this first maneuver? So here you are going along the popliteal fossa, flex the knee and pull the leg out. This is called as Pinard's maneuver. This Pinard's method is mainly done for arrested lower limb in the breech. Next. So when you hold the baby by femoropelvic grip and then you rotate the baby, this is called as Loset's maneuver. Loset's maneuver is done for extended arm or nuchal displacement of arm. Extended arm or nuchal displacement of arm. This is for the aftercoming head of breech. So this maneuver is called as Mauritius smelly wheat maneuver. So this is for the aftercoming head of breech. It is called Mauritius smelly wheat maneuver. So what we do here is we give suprapubic pressure plus malar flexion plus shoulder traction. So this is called Mauritius smelly wheat maneuver. So it is for the aftercoming head of breech. So here we give suprapubic pressure plus malar flexion and shoulder traction. Next, this is called Viga-Martin. So Viga-Martin may you don't give shoulder traction, but you're going to give suprapubic pressure plus malar flexion. So it is only suprapubic pressure plus malar flexion. Yes, Dilip, correct. हम यहाँ पे Piper's forceps भी use करते हैं. ये क्या है? What is this? जब आप बच्चे को पैर से पकड़ के ऊपर खींचते हो, this is called as Burn Marshall. Burn Marshall. Burn Marshall is for the aftercoming head of breech. Burn Marshall. This is called dorso-posterior breech. Dorso-posterior breech is mainly for the, this maneuver is called as Prague maneuver, Prague method. So for the dorso-posterior breech, this is called as Prague method. Okay. Next, this is the Piper's forceps, which you are telling, right? So what is in this Piper's forceps? Piper's forceps may, this is the handle. This is the lock. It has a long and curved perineal. It has a long and curved perineal curve. So it has a perineal curve, which is shank में ये इसको कहते हैं perineal curve. तो इस perineal curve में क्या होगा? It will be long and curved. And these are the blades. So this is called as Piper's forceps. Now, very important is biophysical profile. So what is biophysical profile? To know whether the baby is fine inside or not, we have the biophysical profile. What is a mnemonic which you know about the biophysical profile? So my mnemonic for the biophysical profile is BAN-MO2. BAN-MO2. So B stands for breathing. A stands for amniotic fluid index. No, it is not amniotic fluid index. It is amniotic fluid volume. N stands for non-stress test. MO stands for movements. I have a query here from Pratisha. So Piper's forceps and Wrigley's are completely different. Piper's may you're having a long shank. Wrigley's may you will not have shank and all. Wrigley's may shank will be there, but it will not be so long and curved. Wrigley's will be very small forceps. So breathing, amniotic fluid index, NST and movements. Tone. See, BAN-MO2. BANMOTO. If she is having one cycle of inspiration and expiration, then you'll go give a score of 2. In 30 minutes ultrasound mein, if you have one cycle of inspiration and expiration lasting for 30 seconds, then you are going to give a score of 2. If not, you'll give score of 0. Amniotic fluid volume, single deep vertical pocket of more than 2 centimeters, you'll give a score of 2. NST, if it is reactive, then you'll give a score of 2. Movements, if you're seeing 3 discrete movements, then you'll give a score of 2. Tone, if you have one episode of extension, flexion, extension, then you will give a score of 2. One episode of flexion, extension, flexion. टोटल स्कोर होगा 10. 8 या 10 स्कोर नॉर्मल है. अगर 6 का स्कोर है तो क्रॉनिक हाइपोक्सिया चल रहा है. 0 to 4 है तो अक्यूट हाइपोक्सिया चल रहा है. वेरी गुड. व्हाट इज मॉडिफाइड बायोफिजिकल प्रोफाइल? Modified biophysical profile is amniotic fluid index plus NST. Amniotic fluid index plus NST. Right. Next. So pure perium में uterus height decreasing is also very important, right? So just 2 minutes about pure perium and then we'll go for the gynec. So pure perium में the subinvolution of the uterus has been many times a query. Many students keep on messaging me. So just after delivery, uterus is just below the umbilicus. So after delivery, uterus is just below the umbilicus. That is 20 weeks. So, and the day of delivery is considered to be day 0. So, day 0, uterus is just below the umbilicus. Then uterus starts reducing by 1.25 centimeters per day. Then uterus starts coming down by 1.25 centimeters per day. So day 1, uterus is 1 finger breadth less than 1 finger breadth below the umbilicus. Day 2, it is 2 finger breadth below the umbilicus. Whichever day it is, those many finger breadth below the umbilicus. That's all, yeah. Below. Right, correct. Okay. Normal stage after 2 weeks, correct. So it will go into not normal stage, it will go inside the pelvis. It becomes a pelvic organ by 10 to 12 days. It becomes a pelvic organ by 10 to 12 days because it is 13.5 centimeters above the pubic symphysis. Okay. What are the contraindications of breastfeeding? So the contraindications of breastfeeding are when mother is on anti-cancer drugs or other teratogenic drugs, active herpes simplex on the breast, active and untreated pulmonary tuberculosis, galactosemia and congenital lactose intolerance, galactosemia by galactosemia or congenital lactose intolerance, patient undergoing breast cancer treatment, patient undergoing breast cancer treatment, okay, and mother with IV drug abuse or alcohol. Patient presents on 4th day postpartum with fever more than 100°F for 24 hours, dysuria and foul-smelling lochia. What is the diagnosis? So when you have a foul-smelling lochia and dysuria, all this is puerperal sepsis. So puerperal pyrexia is fever more than 100.4°F for more than 24 hours. Day 1 or day 2, UTI. No, HIV you can breastfeed. HIV you can breastfeed. Day 2 to day 3, it is endometritis. Day 4 to day 5, it is wound infection. Days 5 to 6, septic pelvic thrombophlebitis. Day 7 to 21, it is called mastitis. Day 7 to 21, it is called mastitis. Okay? Right? Okay, next. A primary gravida is in labor from last 12 hours. She is having bleeding per vaginum and having pain, tachycardia present, uterus is tender, fetal heart sounds are absent. What is the possible diagnosis? Uterine rupture, abruptio placenta, placenta previa, PROA. Excellent, Pratyusha. Very good. So what were the factors which helped you to answer that this is abruption? She's having bleeding per vaginum associated with pain. Yes, tender uterus. Heart sounds absent, fine. Right, tender uterus. Okay, what will be the mode of delivery for this patient? What will be the mode of delivery for this patient? Very good. I appreciate the way you're answering. Very good. Can you tell me what will be the mode of delivery for this patient? As it's a dead baby, what should be the mode of delivery? So we will go for vaginal delivery. We'll go for vaginal delivery. No, only if there is a fetal distress, you'll go for cesarean section. Only if there is a fetal distress, you'll go for cesarean section. Otherwise, the mode of delivery is always vaginal. Abruption में why for dead fetus you want cesarean, है ना? Right? So that's about the ops. That's about the ops. Now we'll go for the gynec. Now we'll go for gynec. Yeah, partogram. Partogram also something is one which you are trying to ask me. So partogram may. Yeah. So there are two types of partogram now. We have modified WHO partogram and we have WHO labor care guide. We have modified WHO partogram and WHO labor care guide. So currently I feel they might ask you WHO labor care guide more than modified WHO partogram, to be frank. Okay, now please observe. The first column in the partogram will be mainly the fetal heart rate. And fetal heart rate should always lie between 110 to 160 beats per minute. Next, you have one more column where they'll speak about the amniotic fluid, whether it's clear or whether it's a meconium stain or whether it is blood stain or whether it is intact. If membranes are intact, we write I. If membranes are intact, if membranes are ruptured and there's a clear liquor draining out, you'll write C. If membranes are ruptured and blood stain liquor comes out, you write B. If membranes are ruptured and if there is meconium coming out, you write M. Moulding, you give 1 plus or 2 plus or 3 plus. So moulding. So 1 plus, 2 plus and 3 plus, right? Next, if you see here, there will be regarding the moulding also will be there. So this is about the alert line and action line. This modified WHO partogram starts at 4 centimeters of dilatation and ends at 10 centimeters of dilatation. So this modified WHO partogram starts at 4 centimeters of dilatation and ends at 10 centimeters of dilatation. So 4 to 10 usually will take 6 hours. Based on this concept, they put the alert line. 4 hours away from the alert line will be the action line. Normal partogram should be always left of alert line. So whenever the partogram is here, it is considered to be normal. When partogram crosses this line, you have to refer to her to the higher center and get alerted. And when partogram crosses the action line, you have to do intervention accordingly. So what do you think? Is partogram normal or abnormal here? In the picture which I have shown, is the partogram normal or abnormal? Okay, if you are getting confused, which is the line? This is the line. This is the alert line. Upper wala is the partogram. Is it normal or abnormal? Yes, this is normal. This is absolutely normal because it is left of alert line, right? So this is called descent of the fetal head, which is beautifully happening. Then this is the contractions. Contractions, depending on how many boxes are colored, those many contractions. For example, in this picture, how many boxes are colored? 1, 2, 3, 4. So she has. No, this is normal. This is left of alert line. No. See, this is the line, guys. So it is left of alert line. So this is normal. If it crosses the alert line, it should be always left of alert line. If it crosses the alert line, then it is abnormal. Did you understand? Sunny, did you understand? This is normal. This is left of alert line, so this is normal. See, this is the descent of the fetal head. How many contractions are there? Those many boxes you have to color. If the contractions are mild, you'll just get dots. If the contractions are between 20 to 40 seconds. And if the contractions are more than 40 seconds, you're going to make it complete black. Okay? Right. So next, pulse rate and blood pressure, urine routine, drugs, all that is fine. So I'll show you one more picture. You try to answer. Okay, let us answer this picture now. सबसे पहले, it's not very clear, but yes. Can you see that fetal heart rate is dropping here? So fetal heart rate is dropping. What do you mean by M? What do you mean by M? M means meconium. M means meconium, right? 3 plus means 3 plus molding is there. Now, what is happening to the partogram here? What is happening to the partogram here? Partogram has crossed the action line. Partogram has crossed the action line. Is this okay? Definitely not okay. You have to do some intervention now. What about the descent? There is no descent at all. There's no descent at all. So there is meconium. There is, this has gone beyond the action line. There is 3 plus molding. There is no descent. What do you think? And contractions are adequate. What do you think might be the reason for this partogram? And what should be the mode of delivery for this partogram? Yes, excellent. You have to do some intervention now. And what will be the mode of delivery for this partogram? And what might be the reason for this partogram? Whatever you think, you answer, not an issue at all. So don't you think when the fetal head is completely arrested, you have to better go for LSCS? So you have to go for LSCS here. You have to go for LSCS here, right? So you have to go for LSCS, and this is nothing but cephalopelvic disproportion. So partogram is not very difficult. You have to just, first half is important. Fetal heart rate कहाँ पे है? अगर 110 से 160 के बीच में तो सही है. मेकोनियम है या नहीं है? एडिक्वेट माउल्डिंग कितना है? राइट? एक्शन अलर्ट लाइन से पहले है, अलर्ट लाइन को क्रॉस किया या एक्शन लाइन को क्रॉस किया? डिसेंट कैसा है? कंट्रैक्शंस कितने हैं? These are some of the points which you have to see. That's all. Okay, guys? Right. Let us go for the gynec revision now. So are you all ready for the gynec revision? Okay. So gynec, I'm starting with anatomy and I'll go like everything. I'll try to cover. So we'll start from the anatomy and then we'll go discuss fibroid, endometriosis, HRT, infertility, and then finally we'll land up in the oncology, urogynecology. So everything we'll try to discuss. So let us first start with the anatomy. So in the anatomy, we mainly tend to get questions on the Bartholin cyst. So what is this which I'm showing? I actually told you the answer that this is the Bartholin cyst. So we have Bartholin gland, and Bartholin gland when gets blocked, it results in Bartholin cyst. So these are the Bartholin glands. These are 2 pea-sized Bartholin glands. What we see, these are 2 pea-sized Bartholin gland, right? What is the other name for Bartholin gland? Bartholin gland is also called as greater vestibular gland. Bartholin gland is also called as greater vestibular gland. It lies in the superficial perineal pouch. Bartholin gland, when gets obstructed, it results in Bartholin cyst. Bartholin cyst is not painful, but when gets infected and fills with pus, Then it becomes painful. That's called Bartholin abscess. Bartholin cyst is non-tender, fluctuant, and mobile. And it has high chance of recurrence. So when you initially find it, and it is at the junction of upper two-third and lower one-third lateral wall of labia majora. So this is the Bartholin cyst. It is inner to labia majora. It is at the junction of upper two-third and lower one-third. You can put an elliptical incision on this Bartholin cyst and drain out all the contents. So when it is Bartholin cyst, first you can always try incision and drainage. But if you have recurrent Bartholin cyst, then what is the best treatment we have? For recurrent Bartholin cyst, the best treatment is marsupialization. Marsupialization. That is, you make an elliptical incision, drain out all the contents, and you have to close the, the edges. You have to close the edges. Okay, that is called marsupialization. Okay, right. Next is, if you have Bartholin abscess that is infected, what is the most common organism which causes Bartholin abscess? So the most common organism which causes the Bartholin abscess is E. coli. E. coli. So most common organism which causes Bartholin abscess is E. coli. For Bartholin abscess, it is E. coli followed by gonococci. Incision and drainage. So whenever you have cyst in the anterior wall, it is called Gartner's cyst, which is a remnant of Wolffian duct. Posterolateral cyst is a Bartholin cyst. Maximum times in your exam, you will get an image in the posterolateral aspect of the vagina itself. What is this? Bartholin cyst. If you get that, you're going to answer it. Okay, next is congenital Mullerian malformation. Mullerian duct will give rise to uterus. You all agree with that? What are the 3 steps for the Mullerian duct to become uterus? Anybody can answer this? What are the 3 steps for the duct to become uterus? So there should be formation of 2 ducts, followed by fusion of the ducts. Fusion of ducts will take place from down to up. Fusion of the ducts will take place from down to up, followed by septal resolution. Okay. So Mullerian duct to become uterus, there are 3 steps, guys. 1, 2 ducts should form. Second, the duct should fuse. Fuse should be from down to up. Then the septum inside it should get resolved. When ducts don't form, now I'm discussing the congenital Mullerian malformation. So when ducts don't form, both ducts have not formed at all. MRKH. Yeah, congenital Mullerian agenesis. MRKH stands for Mayer-Rokitansky-Kushner-Hauser syndrome. Mayer-Rokitansky-Kushner-Hauser syndrome. Right? What will be the clinical presentation of MRKH? Jasmine, what will be the clinical presentation of MRKH? Pratyusha, what will be the clinical presentation of MRKH? So MRKH will mainly present you with primary amenorrhea. She'll not get her periods because she doesn't have uterus. Not only uterus, she'll not have upper two-third of vagina. She'll not have fallopian tube. She'll not have cervix. Only the fimbrial part of fallopian tube might be there. Excellent. All of you are correct. Now, another formation defect is when one duct is present and one duct is absent. What do you call that as? When one duct is present and one duct absent, what do you call that as? That we call it as unicornuate uterus. Fusion में So unicornuate uterus will be banana shaped with single fallopian tube. Fusion में both ducts have formed but not fusing at all. Then it is called didelphys. Didelphys will have two uterus, two cervix, two vagina. Two uterus, two cervix, two vagina. Right? Next, lower part would have been fused, but upper part is not fused. Lower part is fused, but upper part is not fused is bicornuate. Two uterus, one cervix, one vagina. See how logical this is. See how logical this is. Correct? So, formation के defects क्या है? MRKH और unicornuate. अब दोनों डक्ट्स नहीं बना तो MRKH, एक डक्ट बना, एक डक्ट नहीं बना तो unicornuate. दोनों डक्ट्स बने बट वो फ्यूज नहीं हो पा रहे तो डाइडेलिफस. इसीलिए आपके पास दो यूट्रस, दो सर्विक्स, दो वजाइना होंगे. अगर दोनों डक्ट्स बने बट फ्यूज नहीं हो पा रहे हैं, only lower part is fused but upper part is not fused, then it is bicornuate. उसके बाद what it should be? Septum, it is not getting resolved. That is called septal. Guys, you got plenty of questions from this chapter. Please listen attentively. So we have septate and arcuate. Arcuate is nowadays being considered to be normal, guys. Septate is the most common uterine anomaly. This is most common associated with abortions and infertility. So this is most common associated with abortion and infertility, and this has the worst reproductive outcome. This has the worst reproductive outcome. Yes, you're all correct. Now, last, what we have is in utero exposure to diethylstilbestrol. In utero exposure to diethylstilbestrol. So if there is in utero exposure to diethylstilbestrol, it will result in T-shaped uterus. In utero exposure to diethylstilbestrol, it will result in T-shaped uterus, infantile uterus. There will be vaginal adenosis. You once got a question, what is the cancer seen with this in utero exposure to diethylstilbestrol? Can you answer what will be the cancer associated with in utero exposure to diethylstilbestrol? While I take off. It will cause vaginal clear cell adenocarcinoma. Vaginal clear cell adenocarcinoma. So I have a mnemonic for remembering all this. My mnemonic is mud be sad. Mud be sad. Bacha fell in the mud, so he's sad. Bacha fell in the mud, so he's sad. Mud be sad. M stands for MRKH. U stands for unicornuate. D stands for didelphys. Didelphys also has good prognosis. B stands for bicornuate. S stands for septate. A stands for arcuate. D stands for in utero exposure to diethylstilbestrol. Easy to remember, guys. Mud be sad. एक बार मेरे साथ बोलो, आप जहां पे भी बैठो एक बार मेरे साथ बोलो. तो सारे congenital anomalies का नाम क्या है? Mud be sad. M MRKH, U unicornuate, D didelphys, mud, B bicornuate, S septate, A arcuate, D in utero exposure to diethylstilbestrol. So it is mud be sad. What is the most common among all this? Septate. Worst reproductive outcome? Septate. Most common associated with infertility? Septate. Most common with abortions septate. कुछ याद नहीं आ रहा है तो septate. Right. Now, what is this instrument which you are seeing here? What is this instrument which you are seeing here? Yes, Bunny, Pratyusha, Jasmine, Dilip, Pradeep. So this is nothing but Leach-Wilkinson's cannula. Yes, excellent. Very good, Jasmine. This is a Leach-Wilkinson's cannula. This one, which is mainly used for hysterosalpingography. So this is Leach-Wilkinson's cannula, which is mainly used for hysterosalpingography. So it has a conical spiral. This conical spiral you'll actually screw into the cervix, and then you push the die. And once you push the die, then you'll take the serial X-rays in order to see what is present inside the uterine cavity. Now, very, very, very important, and which has been asked, guys, what is the investigation of choice and gold standard for uterine anomalies? So the investigation of choice is 3D USG followed by MRI. Whereas the gold standard, correct, gold standard is hysterolaparoscopy. Hysteroscopy to see inside and laparoscopy to see outside. Hysterolaparoscopy. What is the main indication for treating them? The main indication for treating them is when they have recurrent abortions. The main indication to treat them is when they have recurrent abortion. So what is the treatment which we give here? If they have septate uterus, we'll do hysteroscopic transcervical hysteroscopic resection. So if there is a septate uterus, you will do transcervical hysteroscopic septal resection. And if it is a bicornuate or didelphys, then you will do something where you will remove the medial half of the uterus and you join the entire uterus as a single uterus. That is called as Strassman's metroplasty. Strassman's metroplasty. Okay. So this all has been asked as an MCQs, guys. All these are important. Now I'll show you the pictures. You have to answer accordingly. Let us see the first picture. Ideally, this, if you get in the exam, the best answer will be cannot determine, because ideally bicornuate should not be determined on HSG. So if you're seeing here, the intercornual angle is more than 60 degrees. Intercornual distance is more than 4 centimeters. It's an outdated classification. Based on that, this is bicornuate. The intercornual angle more than 60 degrees and the intercornual distance more than 4 centimeters. Based on that, this is bicornuate. So this is the HSG showing 2 uterine cavities, and this is the laparoscopy showing two fundus. 2 uterine cavities and 2 fundus. What do you think is this? So this is also bicornuate, but this is bicornuate from hysterolaparoscopy. This is bicornuate on hysterolaparoscopy. See this one. So this is the septate. This is the septate. But when you're seeing from outside, it is single. But when seeing from inside, it is two. So this is septate on hysterolaparoscopy. What do you think is this one, guys? What do you think is this one? See this one? 1, 2, 1, 2, 1, 2. Yes, this is didelphys. This is didelphys. Absolutely correct. See, MRI can differentiate the bicornuate and septate well. So how do we differentiate on MRI bicornuate and septate is, this is the cornu. Draw a line joining both the cornu and check the fundal contour. The fundal contour, the midpoint of the fundal contour is dipping down from the line joining both the cornu, then it is bicornuate. So draw a line joining both the cornu. The fundal contour is dipping down from the line joining both the cornu, then it is bicornuate. See this one. And this is the fundal contour. So if fundal contour is above the line joining both the cornu, then this is septate. Right? So draw a line joining both the cornu and then the fundal contour. If fundal contour is above the line joining both the cornu, then it is septate. So this is bicornuate. And this is septate. Okay. Now what is this one, guys? What is this one? This is unicornuate. This is unicornuate. A single banana shaped uterus with a single fallopian tube. This is unicornuate. So that's about the uterine anomalies. So can you answer this question? Bicornuate uterus is due to incomplete fusion of uterine cavity, incomplete fusion of paramesonephric duct, incomplete fusion of mesonephric duct, incomplete formation of vagina. So it is due to incomplete fusion of Mullerian duct. The other name for Mullerian duct is also called as paramesonephric duct. So it is due to incomplete fusion of paramesonephric duct. No. It is not due to uterine cavity incomplete fusion. It is due to inadequate incomplete fusion of Mullerian ducts. And incomplete fusion, the other name for Mullerian duct is paramesonephric duct. The most important indication for surgical repair of bicornuate uterus is infertility, dysmenorrhea, menorrhagia, habitual abortion. It is the recurrent abortion or the habitual abortion. The main reason why we are going to treat the bicornuate uterus is because of the recurrent abortions which he is having. What is the treatment of bicornuate uterus? Now, reproductive physiology or endocrinal cycle, I just want you to remember that from the hypothalamus, you will have pulsatile GnRH. From the hypothalamus, you will have pulsatile GnRH. So from hypothalamus pulsatile GnRH, it will go on the pituitary gland to release FSH and LH. That will go act on the ovary to release estrogen and progesterone. That will go act on the uterus. And for this to happen, you require leptin and kisspeptin. And to downregulate the pulsatile GnRH, we have GABA and neuropeptide Y. So normally this is important, which you should know. Now regarding the graph, the first half of the menstrual cycle, it is FSH which is important, because FSH is responsible for the recruitment of the follicles and selection of the dominant follicle. So in the first half of the menstrual cycle, FSH is high. Second half, in the gonadotrophins, we mainly have the LH. At the time of ovulation, you'll have both FSH surge and LH surge. Can you see here? How many peaks of estrogen you will have? Estrogen will be 2 peaks. One just before the ovulation, second on day 22. Day 22, along with progesterone peak, you'll have estrogen peak also. So what should be the level of estrogen in order to cause LH surge? So estrogen should be 200 picogram per ml, lasting for 48 to 50 hours. In order to cause the LH surge. Right? So estrogen will have 2 peaks. One just before the ovulation, another on day 22. Day 22, you'll have both estrogen and progesterone peak. Right, correct, excellent. Very good evening, Roy. How are you? Right, now, any deviation from the normal bleeding are mainly considered under the abnormal uterine bleeding. All the causes of abnormal uterine bleeding has been divided into palm coin classification. Palm coin classification, right? So P stands for polyp. Everything we will touch the most important points. Okay? P stands for polyp. A stands for adenomyoma. L stands for leiomyoma, fibroid. M is malignancy. C is coagulopathy. O is ovulatory dysfunction. E endometrial. I iatrogenic, and N not defined. Okay. So all the causes of abnormal uterine bleeding are mainly divided into palm coin classification, right? So polyp, adenomyosis, leiomyoma, malignancy, C coagulopathies, O ovulatory dysfunction, I iatrogenic, and N not defined. Right. So now coming to polyps. So what is the classical appearance of the polyp? So what is the main symptom of polyp? Polyp exam में main symptom होगा intermenstrual bleeding. That is bleeding in between the periods. So polyp में they'll have intermenstrual bleeding. And when you check the USG, you will see a homogeneous echogenic mass. When you check the USG, you will see the homogeneous echogenic mass. No. Where do we see ring of fire appearance? Where do we see ring of fire appearance? So, yes, this is a homogeneous echogenic mass. Right? And when you see a Doppler, you will see only one vessel going inside the polyp. That we call it as feeding vessel sign positive. Yes. Ring of fire appearance is in the ectopic pregnancy. Feeding vessel sign positive. So polyp, it will, the main symptom of the polyp will be intermenstrual bleeding. So it is a homogeneous echogenic mass, and you will see one vessel going inside that mass, that is called as feeding vessel sign positive. And because of that polyp, they can have infertility and all. What will be the treatment for this polyp? Remove the polyp. Hysteroscopic polypectomy. Yes, you can see a beautiful feeding vessel sign positive. Hysteroscopic polypectomy. Right, chalo, next one. Next is adenomyoma. Adenomyoma. So this is also called as adenomyosis. So it is the presence of functioning endometrium in the myometrium. Presence of functioning endometrium in myometrium. So adenomyosis or adenomyoma is where you have presence of functioning endometrium in the myometrium, right? So if you observe here, this is the small cysts. These are our small cysts which have gone into the myometrium. Can you see here? Can you see here? So what will be the presentation of this patient with adenomyosis? History mein, exam mein, any question which stresses more on pain, painful menstruation, congestive dysmenorrhea, your brain should first tell you three things: either endometriosis or adenomyosis or fibroid. Adenomyosis is seen in multiparous, whereas fibroid is seen in nulliparous. So this is seen mainly in multiparous. So they will have congestive dysmenorrhea plus dysmenorrhea. On examination, uterus will be uniformly enlarged. Globular. Uterus is uniformly enlarged, globular, and it is tender uterus. And this tender uterus, we call it as Halban sign. This tender uterus, we call it as Halban sign. Okay. Right. Can you tell me what is the appearance of this adenomyosis on USG? What is this appearance called as? See, you're seeing some endometrial tissue going into the myometrium, and it is making it look like a black and white. So it's a heterogeneous echo pattern with black and white appearance. So that is why this is called as salt and pepper appearance. So on USG, if they give adenomyosis, either this picture or this picture, you should answer. If they give you this picture, you should answer. Am I clear? These are all some things which I've repeated. So this is called salt and pepper appearance. Yes, excellent, Pratyusha. So this is called salt and pepper appearance or Venetian blind appearance or Venetian blind appearance, right? Now, what is the treatment? So treatment may, the first line is progesterone. Estrogen will help in growth. So I'm going to give first line as progesterone. So I mainly use LNG ICD as the first line, but whereas the definitive treatment is hysterectomy. Definitive treatment is hysterectomy, right? Okay, so that's about the adenomyosis. Actually, I didn't tell you one thing, that investigation of choice is MRI. The junction between endometrium and myometrium is called junctional zone. That junctional zone thickness will be more than 12 mm. The junction between endometrium and myometrium will be more than 12 mm here. So that's everything about the adenomyosis. Now coming to the fibroid. Fibroid is also called leiomyoma. Fibroid is also called as leiomyoma or fibromyoma, right? Bunny, where are you? When you have a fibroid here, what do you call this type of fibroid as? This fibroid, what do you call this fibroid as? Yes, this is intramural fibroid. This is intramural fibroid. Excellent. Can you name this fibroid? Can you name this fibroid? Okay, वो intramural है. अभी ये वाला. So this is subserosal. Gone outside the mural extremity. Good thinking, but this is called subserosal. It is called sessile subserosal because it doesn't have a stalk. This is pedunculated subserosal. This is pedunculated subserosal, whereas this is sessile subserosal. This is intramural. See, this one is submucosal. These are the main important three types of fibroid, guys. Now, can you tell me which is the most common among these three? Which is the most common among these three? Is it submucosal या intramural या submucosal? इन तीनों में से सबसे ज्यादा कॉमन कौन सा है? Fibroid is a tumor of muscle. Fibroid is a tumor of muscle. So it first arises in the muscle. उसके बाद either इस तरफ धकेला जाता है या उस तरफ. So it can either become submucosal or subserosal. But first it arises in the muscle. Okay. So most common is intramural. No. Most symptomatic is submucosal. Most common is intramural. What is the most common degeneration in the fibroid? Fibroid is mainly nulliparous. It's seen in nulliparous. It is both estrogen and progesterone dependent. What is the most common degeneration? Yes. Most common degeneration is hyaline degeneration. Least common degeneration is sarcomatous degeneration. So most common is hyaline degeneration, whereas least common is sarcomatous degeneration. Most common degeneration in pregnancy. Yes, excellent. Only during pregnancy it is red degeneration, which is mainly seen in second trimester, and they'll mainly present you with pain and fever. Treatment is symptomatic, but never remove fibroid during pregnancy. Chalo, symptoms mein. More than 50% of the fibroids are asymptomatic. They don't have any symptoms. Symptoms purely depend on the site of the fibroid. So I will tell the site, you tell the symptom. Chalega? I will tell the site, you will tell the symptom. Okay, before that, this one, this is the USG of the fibroid. So fibroid, whereas see, यहाँ पे देखो polyp कैसे दिखता है? Polyp सफेद या ग्रे, जो बोलना है. यहाँ पे fibroid कैसे दिखता है? Black. So when something looks black, it is called hypoechoic. Hypoechoic. So fibroid is homogeneous and hypoechoic. Homogeneous and hypoechoic. Okay? Chalo. What will be the symptom of first submucosal fibroids? Most symptomatic are submucosal fibroid. So what will be the symptom of submucosal fibroid? Yes, submucosal fibroid will cause heavy menstrual bleeding. Heavy menstrual bleeding. Not only it causes heavy menstrual bleeding, excellent messy, it causes infertility. It causes recurrent abortions. What will be the symptom of intramural fibroid, guys? What will be the symptom of intramural fibroid? What is the symptom of intramural fibroid? So intramural fibroid, excellent. It will cause dysmenorrhea, pain. Intramural fibroid, dysmenorrhea, correct. What will be the symptom of subserosal fibroid? Subserosal fibroid, if it is sessile, it causes pressure symptoms. And if it is pedunculated, then it will lead to torsion. So subserosal fibroid, if it is sessile, it will cause pressure symptoms. If it is pedunculated, it can undergo torsion. Next, what will be the symptom of anterior cervical fibroid, guys? What is the symptom of anterior cervical fibroid? So anterior cervical fibroid will mainly lead to increased frequency of micturition. Anterior cervical fibroid will mainly lead to increased frequency of micturition. Whereas posterior and central cervical fibroid, this will cause retention of urine. So anterior cervical fibroid will lead to increased frequency of micturition. Posterior or central cervical fibroid will lead to retention of urine. So those are all the symptoms and we have seen the investigation. Now let's go to the management. Management purely depends on whether she's symptomatic or asymptomatic. Pehle, let us see when she's asymptomatic. If she's asymptomatic, you can do regular supervisions. If she's asymptomatic, you can do regular supervision. If she's asymptomatic, then you can also go for surgery. So when will you do surgery? When diagnosis is not certain. When it is a pedunculated fibroid and when there is unexplained infertility. So when it is asymptomatic, you can do regular supervisions and you can also go for surgery. So when do you go for surgery? When the diagnosis is not certain. When it is a pedunculated fibroid. When you have unexplained infertility. Whatever might be the size of the fibroid, if they don't have symptoms, don't remove it. Fibroids are like with bindas attitude, live and let live. तुम भी रहो, हम भी रहेंगे, साथ में रहेंगे, right? And in menopause, anyway, fibroids are estrogen and progesterone dependent. So in menopause, fibroids will regress in size. Symptomatic में you have medical management and surgical management. Symptomatic में medical management में the drug of choice is GnRH analogs. GnRH analogs not only decreases the vascularity to fibroid, they can also decrease the size of the fibroid. So symptomatic में medical management, you mainly have the GnRH analogs. Now, surgery depends on what age group they are. If somebody is nulliparous, whatever might be the size or site of the fibroid, if she is nulliparous and she want to conceive in the future, then what are we going to do? We are going to go for myomectomy. Complete removal of the fibroid. But uterus will be left in situ. That is called myomectomy. Somebody is family complete 50 years and they don't want, they're like fed up with this fibroid and the uterus, you can do hysterectomy. You also have minimally invasive surgeries, that is called uterine artery embolization or HIFU, high intensity focused ultrasound. So uterine artery embolization mein you push emboli and then you wait for the fibroid to shrink in size. HIFU mein you pass ultrasonic radiations in order to shrink the fibroid. But in both, where it is elderly women but don't want to conceive in future. Did you understand? If she want to conceive in future, myomectomy. Family complete old, want to remove the uterus, hysterectomy. Family complete old but want to preserve the uterus, uterine entry embolization and HIFU. Now you solve the MCQs and tell me, okay? 36-year-old female with 2 alive children complains of dysmenorrhea and dyspareunia. Okay, this is not the question. Wait. Yeah. Suchita, a 29-year-old nulliparous woman, complains of severe menorrhagia and lower abdominal pain since 3 months. On examination, there is a 14-week sized uterus, fundal fibroid. The treatment of choice is see, it is such a huge fibroid. She is nulliparous. She is 21, 9. She want to conceive in future or she doesn't want to conceive? She want to conceive, no? Ha, correct, Pratyusha. Any nulliparous, best treatment is myomectomy. Nulliparous में हमेशा best treatment is myomectomy. Understood? Now please read this question. So nulliparous I told myomectomy, but read this question. Age को also consider करो, ठीक है? 45-year-old nulliparous is being evaluated for inflammatory bowel disease. She came for inflammatory bowel disease. Ultrasound shows a 5 centimeter fundal fibroid and a 3 centimeter anterior wall fibroid. Her periods are regular 4 to 5 days in 30 days. She denies any intermenstrual bleeding. She's up to date with her smears with normal results. What will be the management? Myomectomy, GnRH analogs, hysterectomy, wait and watch. In this question, she doesn't want to conceive. She has come for what problem in this question? She has actually come for what problem in this question? She has actually come for her inflammatory bowel disease. Yeah. So she's not bothered about her fertility now at 45 years. Naughty नहीं बनना है 45 में अभी, है ना? So what you want to do? Just wait and watch. Just wait and watch. Although she has fibroids, she's not bothered about them. So you also don't bother, no? She's not having any problem due to fibroid. Leave her alone. Okay, next question. अभी ये क्वेश्चन सही से आंसर करना है, ठीक है? 36-year-old nulliparous woman is being evaluated for secondary subfertility. She has regular heavy periods lasting for 7 days every month. Ultrasound shows a 4 centimeter pedunculated fibroid impinging into uterine cavity. What is the management? So she's 36 years. She is nulliparous. She has come to you for infertility. She has a 4 centimeters fibroid impinging into uterine cavity. If it is impinging into uterine cavity, it means where is the fibroid? And what is the treatment for it? Laparoscopic myomectomy, GnRH analogs, hysteroscopic myomectomy, wait and watch. Yes, as it is inside the uterine cavity, see it is impinging into uterine cavity. So when it is inside the uterine cavity, will you remove laparoscopically or will you remove hysteroscopically? अगर प्रॉब्लम अंदर है तो आप बाहर से अप्रोच करोगे कि अंदर से अप्रोच करोगे? ऑब्वियसली अंदर से अप्रोच करोगे ना, तो अंदर से अप्रोच करने को क्या कहोगे? हिस्ट्रोस्कोपिक मायोमेक्टोमी. Okay. Coming to the amenorrhea. There are two types of amenorrhea, primary amenorrhea, secondary amenorrhea. So primary amenorrhea is absence of secondary sexual characteristics, no menses till age 13 years. In the absence of secondary sexual characteristics, no menses till age 13 years. And in the presence of secondary sexual characteristics, no menses till age 15 years. No menstruation after 3 years of attaining secondary sexual characteristics. So primary amenorrhea, प्राइमरी एमनोरिया के डेफिनेशंस क्या है? In the absence of secondary sexual characteristics, no menses till age 13 years. In the presence of secondary sexual characteristics, no menses till age 15 years. No menstruation after 3 years of attaining secondary sexual characteristics. Okay. And no menses by age no menses by age 14 years. No menses by age 14 years in the presence of no menses by age 14 years in the presence of hirsutism, eating disorders, and one more is there, excessive exercise. That is PCOS going directly into primary amenorrhea. PCOS going directly into primary amenorrhea. Okay. So you tend to get again questions from primary amenorrhea. You have false primary amenorrhea and true primary amenorrhea. Just by seeing this picture, can you tell me what is this? Yeah, this is called false primary amenorrhea or cryptomenorrhea. But what is this which will present you with false primary amenorrhea or cryptomenorrhea? Yes, excellent. This is called imperforate hymen. Here, the menstrual blood is not able to come out because of the outflow tract obstruction. Here, the menstrual blood is not able to come out because of the outflow tract obstruction. So all the menstrual blood starts getting accumulated inside the uterus, and then it into the vagina, then it goes into uterus and fallopian tube, and it can also go into endometriosis, right? So they will present you with mainly with cyclical pain abdomen, and primary amenorrhea. Per rectal, you will have bulge throughout the vagina. The only difference between imperforate hymen and transverse vaginal septum mein, transverse vaginal septum mein bulge will be present only in the upper part of vagina, whereas imperforate hymen mein the bulge will be present throughout the vagina. In transverse vaginal septum, the bulge will be present only in the upper part of the vagina. In imperforate hymen, the bulge will be present throughout the vagina. Okay? And per rectal, uterus will be felt. You can do USG to confirm this. And on local examination, you will have a tense, bluish, bulging hymen. Treatment is cruciate incision. Treatment is cruciate incision. Treatment is cruciate incision. Right? Okay. Now, we'll go into the true primary amenorrhea. We'll go into the true primary amenorrhea. We'll take a small 5 minutes break and then start with the true primary amenorrhea. హలో హలో 5 minutes తర్వాత రీస్టార్ట్ చేద్దాము. Right, so I can start. Right, so coming to the true primary amenorrhea. So true primary amenorrhea, am I visible and audible to all of you now again? I think I'm not visible, no? Right. So we'll start with the true primary amenorrhea now. Okay, done. So true primary amenorrhea, whenever the MCQ comes, you all know what is the most common cause of true primary amenorrhea? Most common is gonadal dysgenesis. That is Turner's. Turner's. Whenever you get a question on true primary amenorrhea, you should always first see about the secondary sexual characteristics, whether uterus is present or absent. What is a karyotype? These three things will tell you what is the answer. Secondary sexual characteristics, karyotype, and whether uterus is present or absent. These three things will tell you the answer. Very good, Pratyusha. Second most common is Turner's. Second most common is MRKH. Third most common is AIS. Very good. Excellent. I appreciate. Very good. So now, check further if secondary sexual characteristics are present. Uterus absent. And if the karyotype is 46XX, this is MRKH. And if the karyotype is 46XY, where axillary and pubic hair are absent, axillary and pubic hair is absent, then you will call it as androgen insensitivity syndrome. Then we call it as androgen insensitivity syndrome, right? Next, if it is 46XY with virilization, matlab all everything like male. See, follow these three simple steps. You'll be able to answer always in a patient with secondary primary amenorrhea. So first you have to check for secondary sexual characteristics and uterus, whether it's present or absent. If secondary sexual characteristics are present like breast and axillary hair and pubic hair, then it is MRKH. Secondary sexual characteristics mein breast is present, but axillary and pubic hair are absent, then it is AIS. If secondary sexual characteristic mein breast is absent, but axillary pubic hair, a beard, clitomegaly, all like male it is present, then it is 5-alpha reductase deficiency. Then it is 5-alpha reductase deficiency. Okay, correct. MRKH में you don't have the uterus, but axillary pubic hair and secondary sexual characteristics, everything is present. So MRKH में ovaries are present, right? So what is the treatment for MRKH? Treatment for MRKH is vaginoplasty. Treatment for MRKH is vaginoplasty, and you have to go for, they can have their own genetic child by surrogacy. AIS is a testosterone receptor defect. So testosterone is not able to act on its receptor. So testosterone gets converted into estrogen. Now, because of the estrogen, secondary sexual characteristics will be present. Secondary sexual characteristics will be present. So that's why she's a very well, although she's a male, secondary sexual characteristic like breast will be there, but axillary and pubic hair will be absent. So here, we have to do gonadectomy. And after puberty only, you should do gonadectomy so that she can develop the secondary sexual characteristics. And after you have done gonadectomy, put her on hormone replacement therapy. After the gonadectomy, you have to put her on hormone replacement therapy, right? And then she cannot have her own genetic child. So she has to go for adoption. Yes. Very good, Divya. So you have to give HRT में both estrogen and progesterone, and that too it is after puberty. Correct. Excellent. 5-alpha reductase में testosterone is not able to get converted into dihydrotestosterone. So testosterone is not able to get converted into dihydrotestosterone. That is why they have female external genitalia. They have undescended testes. These testes is secreting Wolffian duct is there, spermatogenesis will be there, and this testis is secreting testosterone also. So this in brief, you should know about the amenorrhea. Yes, you have partial AIS and Reifenstein also, but now I'm going to be precise on what might be asked to you. Now next is, if you have secondary sexual characteristics absent, uterus present, and the karyotype is 45XO, then what is your diagnosis? Turner's. Yes, Turner can present you with both primary and secondary amenorrhea. Turner can present you with both primary and secondary amenorrhea, right? Now, secondary sexual characteristics absent, but uterus is present, and if the karyotype is 46XY, why do we see the 46XY, guys? Turner ke head to toe all features you should know, guys. Turner head to toe all features you should know because they have been asked previously in the exam question. This is Swayers. This is Swayers. So Swayers may. Why do we have Swayers? Swayers will have is because of the SRY gene mutation. SRY gene mutation. Yes, Turner's can be both primary as well as secondary amenorrhea. Turner mosaic will present you with secondary amenorrhea. Secondary sexual characteristics absent, but uterus present, and 46XX. Then this is Callemans. So Callemans will have absence of GnRH production plus anosmia. Absence of GnRH plus anosmia. Turner's treatment with hormone replacement therapy. This also hormone replacement therapy. Here you can give injection pulsatile GnRH. So for your last minute revision, if you know these 6 causes, you can answer very well in the exam. At least these 6 causes are most important to us. Okay. When anything is not matching these 6 causes, go to whatever option available. When anything is not matching the 6 causes, go to whatever option available. Next, coming to the, how do you differentiate? Last recent tiny CET mein, they have given MRKH. See, AIS mein you have different varieties. Complete AIS mein all receptors are not functioning. You also have partial AIS. Partial AIS mein some receptors are functioning and some receptors are not functioning. You also have Reifenstein where most of the receptors are functioning. Only few receptors are not functioning. Okay. Reifenstein will present you with male infertility. Partial AIS will have scanty axillary and pubic hair. Right. So coming to the one question we'll solve. 19-year-old patient complains of primary amenorrhea. She has a well-developed breast and pubic hair. But on examination, there was absence of uterus and vagina. likely diagnosis is? XYY, Mullerian agenesis, gonadal dysgenesis, and Klinefelters. Excellent. This is MRKH. Right. Okay, now one more question. 16-year-old girl with blind vagina and absent uterus presents to you. The investigation you would like to do first is intravenous pyelography, FSH, karyotyping, CT scan of the pelvis. So absent uterus can be MRKH, can be AIS, can be phi alpha reductase. All these mainly I can differentiate by the karyotype. So I would like to first go for karyotyping. Yes, karyotyping. Excellent, excellent. Coming to the secondary amenorrhea. Yes. Secondary amenorrhea is absence of menstruation for 3 months or less than 9 cycles in a year. What is the most common cause of secondary amenorrhea? Pregnancy. What is the most common cause is pregnancy. Most common cause is pregnancy, right? And what is the most common pathological cause? So most common pathological cause is PCOS. Okay. Yes. Now this is, what is this which I'm showing you in the picture? So this is the saline infusion sonography which is showing you the adhesions. And this is the HSG showing you the adhesions, right? Now in India also we have become the diabetic capital. Why India has become diabetic capital? One, direct diabetes. Second, PCOS is one of the major reasons why we have become the diabetic capital and number one. Earlier diabetes was less and PCOS is less, tuberculosis was rise. But now more than TB also PCOS has become so common in India, right? So this is nothing but the Asherman syndrome. So Asherman is adhesion of the anterior and posterior wall of the uterus. Any trauma to the uterine valves can lead to Asherman. Even tuberculosis can also lead to Asherman. HSG is absolutely contraindicated. Investigation of choice and gold standard are laparoscopy. Sorry, hysteroscopy. See inside, no? Treatment is hysteroscopic adhesiolysis. Treatment is hysteroscopic adhesiolysis. After that, you can put a copper T or you can put a condom to prevent it readhesions. So hysteroscopic adhesiolysis. See, these are all the hysteroscopy showing adhesion. See, this is the post-treatment. Okay. Now, ovarian causes may, what are the important we have are premature ovarian failure, and Savage syndrome. Premature ovarian failure and Savage syndrome. So premature ovarian failure is oocyte depletion oocyte depletion before age 30 years, before age 40 years. Oocyte depletion before age 40 years, right? Okay. So premature ovarian failure is oocyte depletion before the age 40 years. Savage syndrome is FSH receptor mutation, can be sporadic. You have many causes for premature ovarian failure. It can be genetic, that is Fragile X syndrome or Turner mosaic. It can be idiopathic, it can be autoimmune destruction, it can be mumps soporitis. Both are differentiated similarly. Both will have FSH more than 40. Both will have serum estradiol less than 20 picogram per ml. Both antral follicle count will be decreased. No, in this antral follicle count will be decreased. यहाँ पे serum FSH is more than 40. Serum estradiol same, less than 20. But here it is not antral follicle count depleting. Antral follicles are not able to mature because of the FSH not able to act. So antral follicle count here will be increased. Antral follicle count will be increased. Okay. Yes. See, how do we differentiate? यहाँ पे premature ovarian failure में antral follicle count is decreased. Here antral follicle count is increased. Here AMH will be low. Here AMH will be more. Okay. Both of them you have to go for IVF with donor oocytes. Both of them we have to go for IVF with donor oocytes. IVF with donor oocytes. Next, pituitary cause mein we have Sheehan syndrome. Somehow Sheehan's is very favorite for all students. Don't you agree? So what is happening in Sheehan's? Sheehan's mein you have postpartum pituitary necrosis due to PPH. PPH causing postpartum pituitary necrosis. PPH causing postpartum pituitary necrosis. What is the first hormone to be lost? First hormone to be lost is growth hormone. First hormone to be lost is growth hormone, right? Other hormones which are lost are prolactin, FSH, LH, TSH, and ACTH. Most common symptom is lactational failure. Absolutely correct. Treatment is lifelong supplementation with estrogen, progesterone, thyroxine, and cortisol. Treatment is lifelong supplementation with estrogen, progesterone, thyroxine, and cortisol. Okay. Prolactinoma. Prolactinoma is the most common pituitary adenoma. You have both microadenoma and macroadenoma. Microadenoma is less than 1 centimeter. Macroadenoma is more than 1 centimeter. The classical triad is amenorrhea, galactorrhea, decreased libido, and infertility. Amenorrhea, galactorrhea, decreased libido, and infertility. When you have a macroadenoma, it can press on the optic chiasma and cause bitemporal hemianopia. Bitemporal hemianopia, right? Pressure symptoms like headache. So check the serum prolactin in fasting state. If it is more than 30, first rule out hypothyroidism. And if it is more than 150 to 200, rule out the prolactinoma. Drug of choice is cabergoline. Drug of choice is cabergoline. If she is pregnant and infertile, then the drug of choice is bromocriptine. Drug of choice is cabergoline. If she is infertile and pregnant, then the drug of choice is bromocriptine. Next, coming to hypothalamic. So hypothalamic में eating disorders, excessive exercise, anything which suppresses the pulsatile GnRH. Eating disorders में anything which suppresses the pulsatile GnRH. So how do we work up for a case of hypothalamus? First, always check UPT. First, check the UPT. I am very much impressed by your preparation, Pratyusha. Keep it up. So just do very well. Matlab, the way you're answering everything, it's almost in your brain. Now, you just have to go and answer. So be positive, be confident, and all the best. So workup may do UPT. Yeah, others also I appreciate. Then you can also measure the serum TSH and serum prolactin. Most common is PCOS. PCOS is an anovulatory cycles. So whenever it is due to anovulation, progesterone will be absent. So first you will do progesterone challenge test. So give her 5 days of medroxyprogesterone acetate, 5 days of medroxyprogesterone acetate and withdraw. Give her 5 days of medroxyprogesterone acetate and withdraw. If she has bleeding, then it is PCOS. If there is no bleeding, even after giving 5 days of medroxyprogesterone acetate, then you should give estrogen plus progesterone challenge test. If still there is no bleeding, then it is Asherman. If bleeding is present, then do serum FSH. Agar serum FSH is less than 5, it's called hypothalamo-pituitary defect. And if it is more than 40 or 40, it is called ovarian failure. More than 40, it's an ovarian failure, right? Very good. That's awesome. Okay, now hypothalamo-pituitary failure can also be called as hypogonadotrophic hypogonadism. Ovarian failure is called as hypergonadotrophic hypogonadism. Ovarian failure is called as hypergonadotrophic hypogonadism. Hypothalamic failure is called as hypogonadotrophic hypogonadism. Correct? So, Ganesh, your preparation is also good. Okay, answer this question. This is one of my favorite questions and it is also a PYQ, right? A 23-year-old female came with the complaints of 4 months of amenorrhea. The FSH and LH were elevated above the normal. When FSH and LH is elevated above the normal, what is your diagnosis? When FSH and LH are elevated above the normal, what is your diagnosis? Thyroid function tests are normal. What is the next step? सबसे पहले you tell me before I show you the options. Whenever somebody has FSH and LH above the normal value, what is your main differential diagnosis which will run in your brain? Excellent. It is the ovarian failure. So what should be the investigation to confirm the ovarian failure? Yes, it is ovarian failure. So what is the investigation which you would like to answer for ovarian failure? See, FSH and LH elevated above normal value, it cannot be pregnancy. So no need to do UPT. No need to do UPT. Okay. So check USG for polycystic ovaries, estimate serum estradiol levels, give progesterone. So ovarian failure may always remember FSH will be very high and estrogen will be very low. So estimate serum estradiol levels. Estimate serum estradiol levels. Child with primary amenorrhea with negative progesterone challenge test and positive combined estrogen and progesterone test. Diagnosis may be diagnosis may be. Which one? See, when you are giving progesterone, see, check for PCOS is not possible. PCOS may you will have LH more, FSH less. PCOS may LH will be more and FSH less. That's why it cannot be PCOS. No need to check for the PCOS. So here, child with primary amenorrhea, negative progesterone challenge test. First option which I'll rule out is PCOD. Because PCOD will have positive progesterone challenge test. But positive combined estrogen and progesterone test. So when estrogen and progesterone test is positive, Mullerian diagnosis may be Mullerian agenesis. No, for Mullerian agenesis, uterus should be there. No, they have positive estrogen and progesterone test. So uterus should be present. So it cannot be Mullerian agenesis. It cannot be Asherman. So what is the only answer left? Prolactinoma. So now let's go to the PCOS. PCOS is currently the most common endocrinal disorder. PCOS is the most common endocrinal disorders in the reproductive age group. It is the commonest cause of anovula infertility and it is a treatable cause of infertility. What is the pathophysiology? There are two variants in PCOS. One, it is polygenic. You know, there are many genetic factors which are involved when we get PCOS. So most patients, because of the genetic outcome, they have insulin resistance. Almost 80% of them. So because of the insulin resistance, they have increased insulin and increased IGF-1. This increased insulin and IGF-1 will go act on the theca cells and it will cause theca cell hypertrophy. This theca cells will produce more and more testosterone. So there will be increased testosterone. This testosterone will enter into the ovary where it gets converted into estradiol. There's also some amount of the testosterone which goes into the fat cells. Where it gets converted into estrone. So some amount of the testosterone will go into the fat cells where it gets converted into estrone, right? So now this estradiol or estrone, both are high estrogenic state. So in high estrogenic state, what will this lead to? This will downregulate the FSH and this will upregulate the LH. And that in turn again will lead to theca cell hypertrophy. So both estradiol and estrone will downregulate the FSH and will upregulate the LH. That will in turn again lead to theca cell hypertrophy. What is the most potent form of estrogen? Very good. This was asked as a question, no? Always remember, E2, estradiol, is the most potent form of estrogen, followed by E1, estrone, followed by E3. So first most potent is estradiol, then E1, estrone, and then E3, estriol. Okay? E2. What is this appearance on the ovary? This is called string of pearl appearance. String of pearl appearance. See, string of pearl appearance. What is this, guys? What is this? What is this? Blackish discoloration on the neck or nape of the neck or axilla. Yes, excellent, Bunny. Very good. This is called Acanthosis nigricans. Where do we see acanthosis nigricans? Acanthosis nigricans is mainly seen in insulin resistance. Acanthosis nigricans is mainly seen in insulin resistance. How do we diagnose? We mainly diagnose based on Rotterdam's criteria. So what is Rotterdam's criteria, guys? So Rotterdam's criteria may you'll have at least 2 out of 3 should be positive. So what are those 2 out of 3 positive? Oligo or anovulation. Oligo or anovulation. Hyperandrogenism, clinical or biochemical. So oligo or anovulation, hyperandrogenism, clinical or biochemical, 12 or more than 12 follicles of 2 to 9 size in one or both the ovaries, and ovarian volume more than 10 ml. Or ovarian volume more than 10 ml. Right? Okay. So PCOS or PCOD, at least 2 out of 3 should be positive. Oligo or anovulation, hyperandrogenism, clinical or biochemical, 12 or more than 12 follicles of 2 to 9 size with one or both ovaries on USG, or ovarian volume more than 10 ml. There is also something called as Eschrey. Eschrey criteria, it is more than 20 follicles. Eschrey, everything is same, but only differences. It is more than 20 follicles, not more than 12 follicles. It is more than 20 follicles. Yes. So as Roy told, if they're asking you the natural estrogen, most potent is estradiol. If synthetic estrogen, then conjugated equine estrogen is the most potent. Synthetic में conjugated equine estrogen is the most potent. Coming to the treatment. Somebody has irregular cycles, always go for OC pills, which is 3rd or 4th generation OC pills. That is which contain desogestrel, gestodine, norgestimate or cyproterone acetate, drosperinone. So 3rd and 4th generation OCPs. Somebody is obese, give them metformin and oral contraceptive pills. They have insulin resistance, give metformin. If they have hirsutism, then it is OCPs with cyproterone acetate. They are infertile, then you are going to give letrozole first line, clomiphene citrate second line. This table is the most important for you to answer for the infertility. So irregular cycles with oligomenorrhea and secondary amenorrhea, it is OC pills, which are 3rd or 4th generation. Obesity, it is metformin plus OCP. Insulin resistance, it is metformin. Hirsutism, what is the first line drug? Hirsutism, the first line drug is OCPs containing cyproterone acetate. Infertility, it is letrozole first line, followed by clomiphene. Last resort is like this. See, if they give you this picture in the exam, try to answer. This is called laparoscopic ovarian drilling. Laparoscopic ovarian drilling. Laparoscopic ovarian drilling. So laparoscopic ovarian drilling may, through the laparoscopy, you're going to burn the ovary. Burn, you're going to make holes in the ovary. 4 holes, 4 depth, 40 megavolts. Everything 444. That's about the PCOS. That's about the PCOS. What is infertility? Infertility is inability to conceive in spite of regular 1 year of unprotected intercourse. But if the age of the couple is more than 35, then 6 months is the cutoff. Both male and female can contribute for infertility. So the first investigation which you'll do whenever a couple comes to you with infertility, it will be semen analysis. Semen analysis. Ovaries account for 30 to 40% of the infertility, and tubes also account for 30 to 40% of infertility. All WHO has categorized all the factors for infertility, anovula infertility, into mainly 4. Class 1 is hypothalamo-pituitary failure, like Sheehan's or Kallman's. Sheehan's or Kallman's. What will be the management for Sheehan's or Kallman's? Pulsatile GnRH. Pulsatile GnRH. Hypothalamo-pituitary disturbance is PCOS, where you can give letrozole or clomiphene citrate. Ovarian failure, IVF with donor oocytes. Hypoprolactinemia, bromocriptine. What are the indicators of ovulation? What are the indicators of ovulation? So they'll have regular cycles. What is mid-cycle ovulatory pain called as, guys? Mid-cycle ovulatory pain is called as mitral smudge. Mid-cycle ovulatory pain is called as mitral smudge. Primary dysmenorrhea. That is, they'll have pain only on the first day of the menstrual cycle. Other days, they'll not have pain. Right? NSAIDs will be helpful. And it is considered to be physiological due to release of prostaglandins and a tight cervical os. Cervical mucus changes also will tell us whether they're having ovulatory or anovulatory cycles. So before ovulation, cervical mucus should be under the influence of estrogen, thin, copious, can be stretched between two fingers, called spin barket, and furning positive. You once got a question that why do we see this furning? Guys, can you tell me why do we see this furning? So this furning is mainly due to sodium chloride crystallization on mucin threads. Sodium chloride crystallization on mucin threads. After ovulation, it is under the influence of progesterone. So under the influence of progesterone, it will lead to thick, scanty, cannot be stretched, breaks on stretching, and furning absent. There will be raise in basal body temperature post-ovulation due to norepinephrine and progesterone. You can measure serum progesterone, day 22, more than 5, ovulatory cycle. You can measure urinary LH on day 14. USG may you will see trilaminar endometrium. Endometrial biopsy on day 22 can be done, and there will be increased intermediate cells on the vagina post-ovulation because intermediate cells are under the influence of progesterone. These are all the indicators of ovulation. So once you got a question where they have included both urinary LH surge on day 14 and day 22 serum progesterone. If you have both day 22 serum progesterone and urinary LH surge on day 14, which one will you choose, guys? If you have both, which one will you choose? No, you have to choose serum progesterone. Serum progesterone can assess the infertility or can tell you whether they are ovulatory or not, then LH surge. So you have to go with the serum progesterone. Yes. So management is mainly with ovulation induction drug. You can give either clomiphene citrate or letrozole or gonadotropin. Yes. Furning is mainly due to sodium chloride crystallization on mucin thread. Estrogen causes sodium chloride crystallization on mucin thread. Very good, Roy. Excellent. So treatment for anovula infertility is mainly the ovulation induction drug, which can be either clomiphene citrate or letrozole or gonadotropins. Now, next, this is one thing which has been asked as an MCQ, so I'm directly jumping here. Patient treated for infertility with clomiphene citrate presents with sudden onset of abdominal pain and distension. With ascites, the probable cause is uterine rupture, ectopic pregnancy rupture, twins, hyperstimulation syndrome. Whenever after giving infertility treatment, if you have multiple follicles developing instead of one follicle, right? And it's mainly due to the drugs which we are giving, that we call it as hyperstimulation syndrome. So there will be all these follicles will secrete VEGF, which will cause anasarca. We have to mainly give symptomatic treatment here. We mainly have to give symptomatic treatment. Tubal factors may, the first line investigation is HSG. Tubal factors may, the first line investigation is HSG. So on HSG, the only problem is, because it is non-invasive, it is the first line. The only side effect of HSG is the only problem with HSG is there will be sudden bilateral cornual spasm. So as soon as the drug enters, there will be sudden spasm of both the tubes. So there can be bilateral cornual spasm. So the first line is HSG. The only problem or the only side effect here is there can be risk of bilateral cornual spasm. So when HSG shows bilateral cornual spasm, your next step should be laparoscopic chromoperturbation. Yes. So then your next step should be laparoscopic chromoperturbation. So what is a dye which we use in laparoscopic chromoperturbation? So the dye which we use in the laparoscopic chromoperturbation is methylene blue dye. Gold standard for checking the tubal patency is laparoscopic chromoperturbation. Gold standard for checking the tubal patency is laparoscopic chromoperturbation. When you have proximal block, you'll go for cannulation or catheterization. When you have mid-segmental block, you'll do tubal recanalization. When you have distal or fimbrial block, you'll do neosalpingotomy. So if there is a proximal block, you'll do cannulation or catheterization. If it's a mid-segmental block, you'll do tubal recanalization. If it's a distal or fimbrial block, then you'll do neosalpingotomy. Any severe tubal blocks, best treatment is IVF. Any severe tubal blocks, the best treatment will be IVF. See, this is the HSG. So you have the dye going into the tube and bilaterally coming out, right? See, this is the laparoscopy showing the dye coming out in the pouch of Douglas, right? So lady with infertility with bilateral tubal block at cornu, best method of management is IVF. Same question if they ask you on HSG, diagnosed on HSG, next step in the treatment is, then it will be laparoscopy and hysteroscopy. So coming to the semen analysis, when semen volume, the normal semen volume minimum should be 1.4 ml or more. pH should be 7.2 or more. Count 16 million per ml. Motility 40%, 42% or more. This is as per the new criteria, guys. Progressive motility 32%. Vitality 54%. Morphology 4%. Leukocyte should be 1 million or 1 million per ml. Round cells should be 5 million. Agglutination less than 10%. Once again, we'll discuss. Try to by heart it now. Volume should be 24%, 1.4 ml or more. pH 7.2 or more. Count 16 million. Motility 42%. Progressive motility 30%. Vitality 50%. Morphology 4%. Leukocyte should be less than 1 million. Round cell should be less than 5 million. Agglutination 10%. Right? Aspermia means complete absence of semen. Mainly obstructive may you will have aspermia. Azu means zero sperm count. Asthenospermia means motility is less. Oligo count less than 16 million. Teratospermia is morphology less than 4%. Okay. Now, remember, when sperm count is between 10 to 16 million, go for IUI. What is the most important prerequisite for IUI? Most important prerequisite for IUI is tube should be open, tube patent. Tube is blocked, you'll go for IVF. So when sperm count is between 5 to 10 million, IVF. The only thing what we do in IVF is one oocyte is kept with 50,000 to 1 lakh sperms. When 5 to 10 million IVF you will go. So one oocyte is kept with 50,000 to 1 lakh sperms. Less than 5 million you will go for ICSI. ICSI में one sperm is directly injected into oocyte. ICSI में one sperm is directly injected into oocyte. When sperm count is very less or morphology is also very less, then we go for ICSI. Okay. So that's about the infertility का सारांश or summary. So let us answer this question. 36-year-old Asian woman came with infertility with her husband. She's been trying to conceive since last 2 years. She's overweight and gives a history of irregular periods for last 2 years. Right? Her history and investigation are suggestive of PCOS. She's been using clomiphene citrate for last 6 months. Day 21 progesterone. She's ovulating. What is the management? See, she's taking clomiphene citrate. She is ovulating, but she's not able to conceive, and husband semen analysis is also normal. What should be your next step, or what should be your management? Yes, what should be the answer here? See, what is happening here? She has conceived. B. Arrange IVF. Don't you think you have to rule out? She's ovulating. As she's ovulating with clomiphene citrate, one thing is pretty sure, that you're not going to do bilateral ovarian drilling. You're not going to counsel and offer support. What support you'll offer? Right? I will perform laparoscopy and dye test, and first I'll rule out tubal factors. See, always it need not be only PCOS causing. No, probably along with PCOS, she's having tubes also blocked. So what I'll do, first I'll check for laparoscopy and dye test. If her tubes are proper, then I'll go for IVF. If her tubes are proper, then I'll go for IVF. So now we'll start discussing about the oncology, guys. So coming to CIN, the main villain in CIN is HPV. HPV 6 and 11 will cause warts and laryngeal papilloma of newborn. HPV 31 and 33 will cause CIN. HPV 16 and 18 will cause CA cervix. Best screening method is HPV DNA testing. VIA is for low resource setting. What is this brush? It is seen, no? What is this brush? What is this brush? So this is called iris spatula, where you mainly use for the ectocervix. This is cytobreast. You mainly use it for the endocervix. So iris spatula is mainly used for ectocervix, whereas cytobreast is mainly used for the endocervix. This is the liquid-based cytology breast. This is the LBC breast. It's called Rover's endocervical cytobreast. It's called Rover's endocervical cytobreast. What is the specimen? Sorry, fixative for LBC. The fixative for LBC is methanol. What is the fixative for pap smear? The fixative for pap smear is 95% ethyl alcohol. So the fixative for LBC is methanol. The fixative for pap smear is 95% ethyl alcohol. Okay. Right. Now, what are the new screening guidelines we have? What are the new screening guidelines we have? The new screening guidelines what we have are, as per WHO, this is the most recent. Okay. So you can use VI. You have to use HPV DNA testing. You can treat test and treat, or you can go for test, triage and treat. So you can either do test and treat or test, triage and treat. So test, triage and treat mein you can do HPV DNA testing. Every 5 to 10 years. HPV DNA testing every 5 to 10 years. So you'll do HPV DNA testing every 5 to 10 years. So HPV DNA test, you will do test and treat, test, triage and treat. You'll do HPV DNA testing every 5 to 10 years. And if they are HIV patients, then it is only test, triage and treat. So you will do here HPV DNA testing every 3 to 5 years. Every 3 to 5 years. Okay. Right. Now, how do we treat the patient with CIN? So we mainly have 3 modalities of treatment. CIN 1, you can wait and watch up to 2 years. With pap smear and HPV DNA testing, you can wait and watch for 2 years. And if abnormalities persist beyond 2 years, you can either do ablation or LEEP. For CIN 2, it is either ablation or LEEP. But for CIN 3, it is LEEP for any age group. It is LEEP for any age group. So for CIN 3, it is LEEP for any age group. Somebody asked you what is the best treatment for CIN 3? Then also it is LEEP. What is the best treatment for CIN 3? Then also it is LEEP. Okay. Recurrent CIN 3, better go for hysterectomy. Treatment for CIN, which is extended to vaginal fornices, will be laser ablation. Okay. Or you can go for hysterectomy. Now, this is the cryotherapy. You're taking a cryo probe and you're going to push liquid nitrous oxide or carbon dioxide that will crystallize the entire cervix, and you will have ice formation near the cervix. Okay? This is called cryo probe. Next, this is the LEEP. You have an electric loop which is cutting the cervix. And if you have endocervical lesion, then you'll go for cone biopsy. Always remember, endocervical lesion, cone biopsy. So now, cryotherapy, laser ablation, and LEEP. I want you to be clear with one point. Any age group, any age group, 30, 40, 50, 60, LEEP is the best. Any age group, LEEP is the best. Okay. So cryotherapy mein, you're going to push the liquid nitrous oxide or carbon dioxide and ablate the cervix. So you're going to push liquid nitrous oxide or carbon dioxide and coagulate the cervix. Here you're going to do heat destruction of cervix by CO2 laser. Here you have 2 centimeters electric loop, which is both cutting and coagulating. What is the depth of destruction for cryo? What is the depth of destruction for laser? And what is the depth of destruction for LEEP? So the depth of destruction of cryo is 5 mm. The depth of destruction for laser is 7 mm. The depth of destruction for LEEP is 10 mm. 5, 7, 10. Okay. A 40-year-old woman presents with abnormal cervical cytology on pap smear, suggesting CIN3. What is the next best step? Hysterectomy, colposcopy and LEEP, colposcopy and cryo, conization. So on pap smear, it is what? CIN2 or 3? CIN3. What is your next step? On pap smear, it is CIN3. What is your next step? Hysterectomy, colposcopy and LEEP, colposcopy and cryotherapy, conization. Very good. Excellent, Ganesh. Very good, Ganesh. So it is colposcopy and LEEP. I told you, for CIN3, best management is LEEP. Confirm it with colposcopy and then go for LEEP. Very good, Bunny. So the answer is B. Now coming to the CA cervix. CA cervix may you have 4 cardinal symptoms and 4 cardinal signs. So the 4 cardinal symptoms are irregular vaginal bleeding, pelvic pain, postcoital bleeding, and foul smelling vaginal discharge. Foul smelling vaginal discharge. What is the most specific symptom among these 4? What is the most specific symptom among these 4? Between irregular vaginal bleeding, pelvic pain, postcoital bleed, and foul smelling vaginal discharge, which is the most common, most specific symptom? Postcoital bleed is the most specific symptom. Signs. There will be a hard indurated cauliflower-like growth. There will be hard indurated cauliflower-like growth. It will be firm. That's only hard and firm, right? So it will be fixed. It bleeds on touch. And it is friable. The small pieces can come out. Like cauliflower का ऊपर pieces नहीं निकलते. वैसे same to same यहाँ भी हो सकता है. Now and then we have something called as puff. See, in oncology, I'm mainly discussing the cervical cancer because that is the most common and where we tend to get the questions. So the complications, we have puff. That is pyometra, uremia, and fistula. Most common cause of death is uremia. Most common cause of death is uremia. Staging and management. If you see the staging and management, so see this is mainly CA cervix is clinically staged, but recent guidelines have told that you can use anything, but you have to diagnose it properly. You can use anything to diagnose it, but you have to diagnose it properly. This is the most important, because you tend to get questions on CA cervix. So CA cervix is the most important, right? I don't see, So coming to the staging, stage 1 is confined to cervix. One A1 is less than 3 mm in depth. 1A2 is 3 to 5 mm in depth. 1A1 is less than 3 mm in depth. 1A2 is 3 to 5 mm in depth. Okay. Next, 1B1, 1B2, 1B3. 1B1, 1B2, 1B3. So all these are visible lesions. So 1B1 is less than 2 centimeters in size. All these are more than 5 mm in depth. So 1B1 is less than 2 centimeters in size. 1B2 is 2 to 4 centimeters in size. And 1B3 is more than 4 centimeters in size. So 1B1, 1B2, 1B3. 1B1 is less than 2 centimeters in size. 1B2 is 2 to 4 centimeters in size. 1B3 is more than 4 centimeters in size. All these are more than 5 mm in depth. All these are more than 5 mm in depth. Okay. So stage 1 is completely confined to cervix. Stage 1 is completely confined to cervix. Okay. Stage 2 will go to upper 2/3 of vagina, and it is all about whether parametrium is involved or not involved. 2A means without parametrial involvement. 2B is with parametrial involvement. Again, you have 2A1 and 2A2. 2A1 is less than 4 centimeters in size. 2A2 is more than 4 centimeters in size. So stage 2 is upper 2/3 of vagina is involved. 2A means without parametrial involvement. 2B is with parametrial involvement. 2A1 is less than 4 centimeters. 2A2 is more than 4 centimeters. Stage 3 is lower 1/3 of vagina is involved. Stage 3 is lower one-third of vagina is involved. Stage 3, lower one-third of vagina is involved. So stage 3 may 3A. A means always the other side is not involved. So lateral pelvic wall not involved. 3B is with lateral pelvic wall involvement. 3B, while it is going towards the broad ligament, it also involves the ureter. So 3B also includes hydroureter and non-functioning kidney. So 3A, lateral pelvic wall involved. 3B, without lateral pelvic wall not involved. A means not involved. So 2 में parametrium is involvement. 3 में lateral pelvic wall is important. So 3A, lateral pelvic wall not involved. 3B, lateral pelvic wall is involved. Hydroureter and non-functioning kidney. You also have 3C1 and 3C2. 3C1 is pelvic lymph nodes. 3C2 is para-aortic lymph nodes. 4A, bowel and bladder. 4B, distant meds. 4B, distant meds. 4A, bowel and bladder. 4B, distant meds. Okay. Now, stage 1A1 to 2A1. Stage 1A1 to 2A1. How do I remember? A1, A1 common. 1 to 2. Except 1B3. You'll do surgical management. Advantage of surgery is ovary is preserved. You never remove ovary in this surgery. What surgeries? So 1B1, 1B2 and 2A1. B looks like 3, no? So for 1B1, you will do type 3 hysterectomy, which is also called as radical hysterectomy. For 1B1, we'll do type 3 hysterectomy. That's also called as radical hysterectomy. Plus pelvic lymphadenectomy. For 1A1 and 1A2, it is type 2 hysterectomy. Plus pelvic lymphadenectomy. So for 1A1 and 1A2, it is type 2 hysterectomy plus pelvic lymphadenectomy. For 1B1, 1B2, 2A1, it is type 3 hysterectomy plus pelvic lymphadenectomy. And in all these, ovaries are not touched at all. In all these surgeries, ovaries are not touched at all. Okay? Rest all stages. That is from, I told 1A1 to 2A1, no? So 2A2 to 4B plus 1B3. Plus 1B3, you will do concurrent chemoradiotherapy. That is, first you will give chemotherapy with cisplatin. Followed by radiotherapy. So 2A2 to 4B and 1B3, you will do concurrent chemoradiotherapy. First, you will give chemotherapy with cisplatin followed by radiotherapy. Okay? So radiotherapy mein you can give brachytherapy, guys. Brachytherapy mein you have tandem and ovoids. So there is something called as point A and point B. Point A is 2 centimeters above and 2 centimeters lateral to external os, where you're mainly involving the paracervical lymph nodes. And the radiation what we give here is 80 gray. Point B is 3 centimeters lateral to point A. Here you'll give 60 gray radiation. And here mainly you're targeting the obturator lymph nodes. Am I clear, guys? Next up, what is the vaccine? Vaccine is very, very important. It is mainly made up of L1 capsid protein. Vaccine is very, very important. It is mainly made up of L1 capsid protein. After open, పిల్లలంటే చూసుకో కొంచెం సర్లే. So the vaccine what we have is L1 capsid protein, right? So we have three types of vaccine here. That is Cervarix. Cervarix is outdated, guys. So now the vaccine what we have is Cervavac, and we have Gardasil and Gardasil 9. Cervavac is Indian origin. Indian origin. Serum Institute of India has prepared this first quadrivalent vaccine, which contains 6, 11, 16, 18. Gardasil is also 6, 11, 16, 18. Gardasil 9 is 6, 11, 16, 18, 31, 33, 45, 52, and 58. This less than 15 years, you have to give 2 doses, 0 and 6 months. More than 15 years, 0 to 6 months. Okay. Now, one more very, very, very important what I'll tell you is we have something called as WHO elimination of CA cervix by 2030. So it is, you have, this is called as 3-pillar approach. So 70, 90, 70, 90. So I'm not writing this, but I'm telling you orally. So according to this, 90% of the girls less than 15 years should be vaccinated. 70% of the women middle age should be screened by HPV DNA testing. And 90% of the girls, 90% of the women who are detected with CIN or CA cervix should get treated. So 90% of them who have CA cervix should be treated. 90% of the girls less than 15 years should be vaccinated. 70% should be screened. Right? So that is about the CA cervix and CIN in a crisp manner for you to revise. So now we are going to go for the prolapse. Prolapse management is also important. So I'm going to just give you a summary like which prolapse may what management is done. If you have a young nulliparous, you will do sling surgeries. If you have multiparous and their family is complete, then you will go for Fothergill's operation. If you have multiparous and elderly and family complete, then you will go for vaginal hysterectomy. If you have elderly who is unfit for major surgery, you can first do pessary. If pessary fails, then you can go for Leafold's colpocesis. I repeat once again, if you have young and nulliparous, you can go for sling surgery. If you have young and nulliparous, you'll go for sling surgery. Just a second. So young nulliparous, you'll go for sling surgeries. Multiparous family is complete. We'll go for Fothergill's. Hello. Papa ఇక్కడికి అదే అందుకోసం తీసుకురా సార్ తింటున్నాను. So for young nulliparous, we'll go for the sling surgeries. For multiparous and whose family is complete, we'll go for Fothergill's in reproductive age group. So if you have multiparous, family complete, and elderly, vaginal hysterectomy. But elderly who's unfit for major surgeries, first you can always try with pessary. If it is not is also not helping, then we go for Leafold's colpocesis. So what is sling surgeries? The different sling surgeries what we have are, we have Purandare sling surgery. So Purandare sling surgery mein cervix is anchored to posterior rectus sheath. Cervix is anchored to posterior rectus sheath. Shirodkar sling surgery mein cervix is anchored to sacral promontory. Cervix is anchored to sacral promontory. Kanna में cervix is anchored to ASIS. Kanna, K for Kamar, K for ASIS. Virkud sling surgery में you have right-sided Purandare and left-sided Shirodkar. Right? Now, one more thing. If you have cystocele or cystourethrocoele, then you'll go for anterior colporrhaphy. If you have cystocele or cystourethrocoele, then you'll go for anterior colporrhaphy. If you have rectocele or lax perineum, you'll go for posterior colpoperineorrhaphy. If you have rectocele or lax perineum, you'll go for posterior colpoperineorrhaphy. Right? So if you have cystocele or cystourethrocoele, you'll go for anterior colporrhaphy. If you have rectocele or lax perineum, you'll go for posterior colpoperineorrhaphy. Right? What will you do for enterocele? Oh, no. What will you do for enterocele, guys? Yes, Tali. So we have to obliterate the pouch of Douglas. You have to obliterate the pouch of Douglas. So there what we do is Halban's repair. Halban's repair, Moskowitz surgery, and McCall's scaldoplasty. So for enterocele, you have to obliterate the pouch of Douglas. So to obliterate the pouch of Douglas, you have Halban's repair, Moskowitz surgery, and McCall's scaldoplasty. See, basically, what surgery for what, if you know, that's more than enough for you to rock the prolapse. Yeah, I'll ask you the question, now you tell me. I'll tell you different case scenarios. In class, okay? Please. So now I'll ask you questions, you try to answer, guys. Now I'll ask you questions, you try to answer. If you have patient 33 years, infertile, and with prolapse, what will you do? 33 years, infertile, what will you do? Nulliparous, with prolapse, what will you do? Excellent, Bunny, very good. Sling surgery. Right, correct. If you have 33 years, family complete, para 2, living 2, with prolapse, then what will you do? Now, same 33 years, family complete, para 2, living 2, with prolapse. Now, what will you do? Excellent. Now, you'll go for Fothergill's operation. Correct. Now, if you have 50 years with prolapse, so if you have 50 years with prolapse, we'll go for vaginal hysterectomy. Correct. Excellent. If you have 80 years with hypertension, with diabetes mellitus, with prolapse, almost near the deathbed, then what will you do? Yes, you'll first try with pessary. But if she tells doctor, I really can't keep the pessary, I know I can't come for follow-up, because pessary may you have to come every 3 months. Then we go for Leafords. Leafords may what we'll do? We push the uterus inside and we obliterate the anterior and posterior vaginal walls. Decubitus ulcer also, pessary is the treatment. Decubitus ulcer also, pessary is the treatment. Decubitus ulcer also, pessary is the treatment. Okay? 5 minutes. 5 minutes. Okay, 5 minutes. 5 minutes. Next, if you have vault prolapse, after you remove the uterus, if only vagina is left behind, that is called vault. If you have vault prolapse, what will you do? For vault prolapse, we'll do sacrocolpopexy. That is the best. That is, you fix the wall to the sacral promontory. Sacrocolpopexy. Okay. Alternate to sacrocolpopexy is sacrospinous fixation. Alternate to sacrocolpopexy is sacrospinous fixation. So first you'll always try with sacrocolpopexy. If that doesn't work, then you'll go for sacrospinous fixation. Right? Yes. See, ideally for decubitus ulcer, decubitus ulcer. Okay, 5 minutes. Okay, 5 minutes. Istago. నేను క్లాస్ చెప్తున్నా కదా ఒక 5 minutes ఆగాలి సరే నన్ను గుడ్ గర్ల్ కదా see normally what happens is when you have a decubitus ulcer you have to reduce the decubitus ulcer. The reduction of decubitus ulcer can be either done with a tampon or it can be done with a pessary. If you're using a tampon, you have to put estrogen on that so that the ulcer will heal better, right? Or you can put betadine for the antisepsis, right? Or pessary also with pessary and estrogen and betadine, right? Glycerin will have the hygroscopic action. Glycerin will have the hygroscopic action. Correct. Yes, correct. So next we'll go for the vaginitis, guys. So I'll quickly recap all 3 types of vaginitis. So we have bacterial vagina, we have trichomonas vaginitis, we have candidiasis, and we have bacterial vaginosis. What is the clinical picture in all these 3? Trichomonas mein you will it is an STD. You have to treat both the partners, even if the partner is involved or not involved. You have to treat both the partners. Trichomonas, you will have greenish colored discharge with lot of pruritus, and there will be dysuria and dyspareunia. Right? Candidiasis will have curdy white discharge, and there also it will be lot of pruritus. Okay. Bacterial vaginosis is mainly due to alteration of the microflora. Alteration of the microflora by Gardnerella. Right? So bacterial vaginosis may you'll have only grayish white discharge. Very small, sorry for the disturbance. But there will be no pruritus. Here there will be no pruritus. This is the only one there won't be pruritus. Right? So strawberry cervix is seen with here. Investigation of choice is saline microscopy. Gold standard is culture. Culture on Diamond's media or Feinberg's Whittington media. Candidiasis investigation of choice, you have to do saline microscopy where you'll see the pseudohyphae. Culture will be Sabaroids dextrose agar. Here we have Amsel's criteria. What is Amsel's criteria? pH should be more than 4.5, more than, Pratyusha, it is more than. There will be grayish white discharge. There will be grayish white discharge. And there will be clue cells, bacteria attached to vaginal epithelial cells, more than 20% clue cells. And what is the fourth point? Whiff test positive. That is when you put 10% KOH, you'll have fishy odor. Whiff test positive. That is when you put 10% KOH, you'll have fishy odor. So, right? So, these are the three things. These are the four things what we have, right? The drug of choice for both bacterial vaginosis and trichomonas is metronidazole. Both these, it is metronidazole. Candidiasis, it is fluconazole. Candidiasis, it is fluconazole. Candidiasis, it is fluconazole. Right? Now, I'll just show you the pictures. See, this is cotton woolly appearance, what you see in actinomyces. This is the cotton woolly appearance, which is you see in actinomyces. It is mainly seen with the IUCD users. This is the bacterial vaginosis clue cell, where you're seeing the bacteria getting attached to vaginal epithelial cells. This is sheikh kebab appearance. That is, you know, the pseudo hyphae wound around with the vaginal epithelial cells. So this is called sheikh kebab appearance. This is called sheikh kebab appearance. See, this is a curdy white. This is seen in candidiasis. This is seen in candidiasis. This is the pear-shaped strawberry cervix trichomonas. So these are some of the important points. I tried to cover maximum of the things in the crisp manner in this revision program, right? So all the best, guys. All the best. Read well. Any doubts further, you can always ping me. I'm always available. You can follow me on my Instagram handle and ask me the queries there. That is Dr. Ramyasri 9. Or you can also ask me any queries in my Telegram group. That is Dr. Ramyasri Obgyn Pack. All the best, guys. Be positive. Definitely, you'll come out with flying colors. Thank you so much. Thank you so much. Shoulder dystocia. Actually, there is one nice video, Bunny. If you ping me, I'll just send you the video. It's very nice. That video is very nice. Shoulder dystocia, the questions what they ask is, what is the first step? It is call for help. If call for help didn't help, then you have to go for Mack-Roberts maneuver. That is, you hyperflex both the limbs on the abdomen and abduct. Mack-Roberts maneuver. If that also didn't help, then you will do sustained rocking movement on the shoulder of the baby. That's called suprapubic pressure. If that also didn't help, then you will go for Mack-Roberts, suprapubic pressure. Then you'll go for the Wood's corkscrew. 2 fingers up and down, and then you try to screw the baby. Then with screwing movement, try to remove the baby. Then you go inside and you remove the arm of the baby outside. That's called posterior arm extraction. Posterior arm extraction. Okay. Then we have all fours or Gaskin's position. That is, mother has to lie down like a cat or dog and then remove the baby. That's called all fours or Gaskin's position. If that also didn't help, you can break the clavicle of the baby. That's called clidotomy. Or you can break the pubic symphysis of the mother. That is pubic symphysiotomy. Or you can push the baby's head inside and go for LSCS. That's called Zanavelli. Simple. Okay. Thank you so much, guys. All the best. Prepare well. Enjoy your last 2 to 3 days, in a peace, and do exam very well. Thank you so much. Say all the best to all of them. Say all the best. అయిపోయింది ఇస్తా ఆగు తల్లి.